मैं अपने स्लाइड शेयर जरा चेक कर ला।
श्योर सर।
ठीक है, आ रहा है जी?
परफेक्ट।
ओके, राइट।
सिर्फ मूव करके देख लीजिए।
हाँ, अरे इसमें नहीं चल रहा।
2 बार डबल क्लिक कीजिए स्क्रीन पे।
या ठीक है,
ओके।
राइट, थैंक यू।
गुड आफ्टरनून सर।
हाँ विनीत, क्या हाल है?
फाइन।
नमस्कार विनीत।
हाँ जी सर, गुड आफ्टरनून।
आफ्टरनून। रितेश पहलवान किधर है?
वो थोड़ा काम च बिजी हो गए।
ओके ओके।
कुमार जी, गुड आफ्टरनून, सत श्री अकाल। कैन यू हियर मी?
यस
Hello.
यस।
Slides दिख रहे हैं
नमस्कार
सर? डॉक्टर जी
या
नमस्कार जी।
डॉक्टर संजय वर्मा जी, स्लाइड्स आर मूविंग एंड वेरी वेल
ओके,
विजिबल।
ठीक है सर, ठीक है, थैंक यू सर।
गुड आफ्टरनून डॉक्टर संजय।
हेलो सर।
गुड आफ्टरनून जी डॉक्टर संजय।
हेलो
डॉक्टर
सर।
मेहता, मेरे कुछ कैमरे में कुछ प्रॉब्लम आ रही है, मेरा कैमरा नहीं कुछ।
हाँ नहीं, कोई इशू नहीं, बट फिर भी दिख रहा है थोड़ा सा हेजी है, बट नो इशू।
ओके,
आपका स्क्रीन शेयरिंग अभी स्टॉप करना पड़ेगा।
ओके,
जूम पे स्टॉप शेयर। हाँ ठीक। EFI दिख रहा है?
अभी नहीं दिखा, अब दिख रहा है।
आप देख रहे हैं?
हाँ, मूव हो रहा है।
मेरा वीडियो आ रहा है? Am I visible? Dr. Vineet, can you see me?
Good afternoon, everyone. Good afternoon, sir.
Good afternoon, everyone. Good afternoon. How are you?
हेलो प्रदीप। या
वाह, आज तो एकेडमिक फीस्ट हो रही है।
सर 2 दिन से हो ही रही है। इट्स रियली गुड डिस्कशन। और मैं तो चाहूंगा कि आज तीनों दिन का जो भी बचा हुआ पेंडिंग है, तो सारे के सारे क्वेश्चंस आज के एंड के सेशन में लिए जाए। भले ही प्रोग्राम एक 15-20 मिनट थोड़ा लेट हो गया तो कोई इशू नहीं, बट वी शुड take all the questions in chat box and also all those questions which are there in the mind of faculties also. That will be a beautiful interaction, I think.
Dr. Vineet.
Hello
Dr. Vineet,
Hello,
can
Jay.
you please host for today? I may not be able to host it. I'm in the courts actually. So please do the needful. Please start
Right.
on time, right? A very good afternoon to all of you. I'm sorry, I'll be connected, but I will not host today. Thank you.
No issue. So the recording has started, and I request Dr. Ritesh ji or Dr. Vineet ji to start the proceedings.
Thank you, sir. Good afternoon, everyone. We had a very fruitful discussions on different vaccine topics for last 2 days by very eminent speakers. Today is the last day of concluding day of National Vaccinology module by IAP. Today again we will be covering various vaccination topics. For the first sessions, we have moderators Dr. Gurdeep Singh Dhuria and Dr. Sunil Mehta. Dr. Dhuria is a professor of pediatrics, DMCNH, and also president of Punjab Adolescent Academy. His special area of expertise is pediatric nephrology. Dr. Sunil Mehta is a senior pediatrician based at Khara. He is a secretary, Sahibzada Academy of Pediatrics. Now over to Dr. Dhuria for introducing our next speakers and start the session.
First, Dr. Sanjay Verma will be taking, or Dr. Sashika?
I will be taking the first.
Okay, okay. So I'll invite first Dr. Sanjay Verma. Sir, welcome to the deliberation. I'll first introduce briefly the audience. He's a professor in the PGI Chandigarh, specialty in the infectious disease department, and he has loads of experience in that. If you see the number of publications, I would say more than 150 publication in there, and with a Google Scholar H index of 16. Actually, many of the audience might not be knowing the H index, but I will tell you that this is a very high indexing in if you see the publication. And lots of guest lecture. He's the principal investor in ICMR Center for CRS Surveillance. He's done his RCPCH visiting fellowship. He's also done ESPID Morex Foundation fellowship in there. And he's one of the core member in the ACVIP core committee member as such. So I welcome you, sir, for your deliberation on this very important topics of pediatric vaccinations. So over to you, Dr. Sanjay, sir.
Thank you, sir. Let me load the slides. And just let me know, is it visible?
Yes, sir, it is visible.
Okay, okay. Thank you so much. So good afternoon, everyone. And first of all, let me thank the organizers and especially Dr. Sagar for taking this initiative. This is a very good initiative and very useful initiative, especially for those who are quite away from the main cities and main places. And I'm sure you must have enjoyed the last 2 days talks, which we already has completed. And the task given to me is to cover this influenza vaccine and the rabies vaccine. So I will be trying to cover these two vaccines. So firstly, about the influenza vaccine. So we all know that the IAP currently recommends influenza vaccination for all children below 5 years. So that is what IAP says for children. And we also recommend for pregnant women and healthcare professionals and the high risk population. So as such, there is no consensus whether above 5 years should be giving these vaccines or not. So let me go to the details of that. Okay. So at any given time, which are the strains which are commonly circulating in India at present? So what they are trying to say is that whenever we have an influenza vaccine, we have 4 strains in that, 2 of A strains, which are mainly circulating, and 2 of B strains, which are mainly circulating. You can just see that the prominent lineage from H3N2 and prominent lineage from H1N1. That is from A, and from B, Victoria lineage and Yamagata lineage. So these are the 4 which keeps on coming. And you know that how the process goes on. The one we have vaccine for Northern Hemisphere, one we have for the Southern Hemisphere. So the Northern Hemisphere vaccine comes around October, but the process starts around 6 to 8 months before. So WHO tells which strains to be used in that vaccine for the company manufacturer somewhere around February. So around 6 to 8 months before. And similarly for the other Southern Hemisphere vaccine comes around May, but the process starts something around September. So that is the way things move on. Currently, what the guidelines are saying is that this type B Yamagata lineage is not circulating from something around March 2020. So that is something which is not there. So now the WHO says that for this Northern Hemisphere, even trivalent vaccine can be used. But if quadrivalent is there, then the previous strain of Yamagata will be used in that. Okay, what does the how does the company decide? That is what I was trying to say just now, that global influenza surveillance and response system by WHO, it regularly updates guidelines to manufacture regarding southern and northern region circulating strains. So around 150 public health institutions are there. From there they collect data, and they collect data from India also, and then they make them available by March, April for Southern Hemisphere, and Northern Hemisphere for by September, October. So currently we have vaccine available for the Northern Hemisphere. That is what we have in the market presently. Okay, what vaccine to be used for India? So for the WHO says that in India we have 2 seasons typically. One is there, which is during the monsoons, especially in the southern part of India. And in the northern part, we have two seasons. One is in the rains and one we have in the winters. So that is what we have. So if a country is so wide and having such big seasons, the best time they say is something around before the southern hemisphere, something around May, April, May is the best time for India. That is what they say if someone plans to take annual vaccination. So most part behave like northern hemisphere, but WHO puts it in southern hemisphere. So India should preferably use southern hemisphere vaccine. That is what the WHO says. But if any patient approaches for flu vaccination in any other time, then whatever the latest one is available, that should be used. Like for children, what we say that first vaccine is advised after 6 months. So whenever it crosses 6 months, give the first dose. After 1 month, second dose. And then when the next year starts, possibly the best time will be something around April, May. And then annually that can be given. Okay, split virion and subunit vaccine, that is another concept which is being listened many times. But what you understand, something like wholesale and cellular pertussis, no? The wholesale vaccine causes more effect and more side effect, both. Something like split virion is something like that. And subunit is more refined, like a cellular. So slightly less immunogenic, but side effects are also less. That is what we understand. But how much that is clinically relevant, that is to debate. But so you can just see that this is what is written, that both are available, but this split virion may be slightly more immunogenic in the younger age group. That is what they say. But practically there is not much difference in efficacy between these two vaccines, at least in children, and therefore anyone can be used. Which are the vaccines which are subunit and which is split virion? So most of the available vaccine currently killed one are the split virion one, except the one by Abbott, this Influvac Tetra. That is the one subunit vaccine we are having currently in the market. You can see in this chart they have compared. So they say that split is having outer and inner viral antigens, while subunit is having mainly purified external antigens. And this one is slightly more seroprotection, more T cell response, more immunogenic compared to this. That is what is to understand by these words, but practically probably not much difference. Okay, ACVIP recommendation regarding the dose of vaccine was there when in 2020-21 this was debated, and now they are saying that use the whole single dose. So previously we were saying less than 3 years we use half dose, and after 3 years use full dose. But why these guidelines were there? Because previous vaccines were having more side effects when used in higher dose in a smaller age group. But currently available vaccines are very good vaccines which have very less side effects. So why not give the full dose to even for the younger children? That is the thought. So because of that, now whatever vaccines we have is possibly all the vaccines are going to have the same strength of 0.5 ml even for the younger age group. So that is what is said here. From 6 months to 9 years, 2 doses to be given for the first dose, followed by single dose every yearly. And after 9 years, if you start, only 1 dose is enough every yearly. Okay, ACVIP regarding age group, like I already told you, the less than 5 years now they are recommending from 6 months onward. So that first year you have to give 2 doses, and then you have to give every yearly. Above 5 years, they recommend only for the high risk population. Universal recommendation for giving vaccine for all countries. So that is something we need to, when we decide that it has to happen in the community level usually, you know. So then we need to know the epidemiology of the disease, how much is the disease burden, and which are the age group which are affected more. That sort of a data is probably not available from our countries. Every country decide based on their epidemiology. Like in US, if you see everyone above 6 months, they are supposed to take this vaccine. And they typically say that the age group of 2 years to 49 years, they give live vaccine annually. And 6 months to 2 years and above 50 years, everybody supposed to take killed vaccine annually. So that is what they follow. If you ask me how does the UK follow, so UK doesn't vaccinate less than 2 years. They give 2 years to 59 years, 2 years to 17 years. They use this live vaccine. And after 17 years, healthy adults, they don't give vaccine. any influenza vaccine. They advise above 65 years, they advise killed vaccine. So that's sort of a data we need to create. Surveillance has to be there, which is currently not there. So these are the issues for making guidelines for every individual. And the concept of taking vaccine annually is probably not there in our country yet. So the implementing that will not be that easy. Other than that, who else that like 5 years, less than 5 years children, but with above that comorbidities, you should give. So like what we say to our hospital, if anybody is having hospitalization because of lower respiratory tract infection, like congenital heart disease patients, renal failure patients, like we have this asthma patients, they get admitted very often. I think these are the patients, irrespective of age, they should be advised vaccination, influenza vaccine. We advise them to take, and they ask how long to take. So that answer we don't have, but we give at least for 3 years you take if you are hospitalized. So that kind of things we are following at our center. What about the efficacy? How much this flu vaccine is effective? There are some studies you can see against the confirmed influenza that they have shown 65% efficacy, kill vaccine again the confirmed, serologically confirmed 63%, clinical illness 33%. We don't use live vaccine these days, and now not much studies are available for the live vaccine. For killed vaccine goes something like this. And more than that, there is a belief, there is a concept that most of the respiratory tract infection in younger age group usually start with viruses. And then some of them, like 5% or 10%, convert into secondary bacterial infections. So there is a belief if you can control viral infection, then possibly you can more control the bacterial infection as well. Like the influenza is something around 20%, RSV is 40%. If you give these two vaccines, 60% of the viruses you can control, then bacterial infection automatically goes down. So that is also a benefit of using these viral vaccines. Okay, why there's this change in the volume of the dose advocacy? This I already discussed. The dose 0.5 ml was used earlier for the lower age group, but now they are saying that you use the higher dose. So ACYP now has advised universal 0.5 ml dose for all, and many companies have either received or in process of receiving approval for the same. So the all vaccines are going to come with the 0.5 ml doses. Okay, some questions are there. 3-year-old child comes for flu vaccination. He has taken only one dose previously, and how much doses should this child receive this year? So if you have taken first year one dose, but you are supposed to take two doses first time, no? So if it is coming this time, then I will give 2 doses this time, and then every yearly 1 dose. I think that should be the answer. So any child who has received less than 2 doses in past should receive 2 doses again in this season. Okay, a 4-year-old child has received 2 doses in this first year of life, and now he comes for the flu shot. 1 year he has missed. How many doses should we receive? So once you have received 2 doses, anytime you take, you are only have to take 1 dose. So I think this is what is that the answer is this. And there is some issue with this. Okay. Okay. So after recovering from flu, does the child need a flu shot, and when? So flu is by one virus, but this is protecting against 4 strains. So if you develop flu, then again you can develop with another strain. So it's not a contraindication for not taking flu vaccine. So once the person recovers, you can give a flu shot, even if somebody develops a proven flu infection. So he can take that after recovery. Okay, these are the vaccines available in the market. You can just see that this is written split virion. This is also split virion, and this is also split virion. This is the one which I was saying that is subunit vaccine. That is one is available. Okay, I think I finished the first part, and we will take question at the last, I guess. Okay, so
Yes, sir.
Yes.
Yes, sir. We'll
Okay,
take
so
in the last.
okay, that will be better. So we can go to the second vaccine now. That is the rabies vaccine. So rabies vaccine, you know that what we say for rabies vaccine is that either you have children or you have dog at home. You don't have both. And if you are having both, then you should give pre-vaccination prophylaxis to both. So that is what we feel. And IEP also says that all those who are having pets at home, especially the dog and cat, they should give pre-vaccination prophylaxis to the children. because children are at a very high risk of developing rabies. If you see the numbers, around the 40 to 50% of the bites occurs in 50 to 60% of the bites are in children. So that is why it makes, and in India, if you ask me, around 20,000 people die because of rabies every year. And that is something, a big number which can be prevented. Regarding the vaccines, different type of vaccines are available. Zero cell vaccine, purified chick embryo, and these are the new ones which are becoming available now. But one thing is common, few things are common in all these. One is that all brands are killed vaccines. 0.5 or 1 ml preparation are used as per the brand, IM or ID. All vaccines should have antigen content greater than 2.5 units per dose, to be used within 6 hours of reconstitution. Give IM on deltoid or antilateral thigh, and never give on gluteal region. The reason is that a lot of fat is there, so the doubt about the utility, the uptake of the vaccine, no other site. So children less than 2 years, probably anterolateral aspect of the thigh, and bigger than that, the deltoid is the best site for use. You know that vaccines are used in class 2 and class 3 bites of rabies transmitting animals, and rabies transmitting animals are mammals. In India, around 99% of the rabies is because of dogs, and the remaining is possibly because of monkeys and cats. These are the primary organisms, animals which are responsible for that. Whether to give for this rodents. So rodents, our guidelines of national NCDC says that for rodents bite, it is not required. So you can refer those guidelines. And for the other, like cold-blooded animals like birds, fishes, and this rabies vaccine is not needed, because that temperature is not there for survival of that virus. There is no contraindication for rabies. It's a medical emergency. Vaccine-induced immunity start developing after 7 days of starting the first dose. So after 7 days, there is no use of using immunoglobulins, because vaccines start working by that time. Okay, treatment strategy after bite, you all are familiar with that. That first thing is thorough washing of the wound under running tap water for 10 minutes using soap and detergent, probably the most important step, which many of the people forget. So that is important. And application of antiseptic like povidone, iodine, chlorhexidine, or antiseptic to remove the virus. That is the first thing. And second is immunoglobulins or monoclonal antibodies, whichever is available, can be used for category 3 bites. And category 2 bites also, if there is a wild animal bite. Equine or human, anyone can be used depending upon the availability and scenario where you work. In private setups, mostly the human one is used, and in government setups, the rabies dispensaries, mostly equine one is used. Monoclonal antibodies, both are available. This human one and the double antibody, that the murine one, both are available now. Anyone can be used. Rabies vaccine for class 2 and class 3 bites, any brand can be used. And the other supportive management like tetanus vaccine, analgesics, antipyretics, local and systemic antibiotics as required should be used. You are already familiar about these 3 categories of bites. The category 1, licks on the intact skin, only the wound washing is needed. And if there are minor scratches or licks on the broken skin, but no bleeding as such, then vaccine should be used. And if there is a transdermal bite and the mucous membrane exposed directly with the saliva or exposure to the bats, in that scenario, all the immunoglobulin as well as vaccine to be used. The rule of this watching the animal for 10 days is primarily for the dogs. So if that survive for the 10 days, then probably vaccines can be omitted, but that doesn't apply for the other animals like monkey and cats. Probably it doesn't fit that well. Okay, what is the post-exposure prophylaxis schedule for rabies vaccination? We all know that is the 0, 3, 7, 14, and 28. The 5 doses are the one which was recommended. But the WHO now says the last dose can be omitted. So the 4th dose can be given anytime between 14 to 28 days. So the 2 schedules are there. but the NCDC still insists on that schedule what the previously 5-dose schedule we are following. Which one to use? So again, the WHO gives guidelines for the governments to make policies, and governments give their own guidelines. So if there is a difference in opinion between two, then possibly better will be to stick to the national guidelines. So I will be preferring giving 5 doses instead of 4 to save me in the case of issues in the court, because the national guidelines still goes with the 5 doses. So that is what is written here, the 4-dose WHO, and that is the 5-dose which we are following. And government is yet to rectify recent WHO guidelines as per PEP schedule. Can post-exposure rabies prophylaxis be given intradermally? Yes, that is what is being done in government dispensaries. They are using that schedule 22202, 037, 14 they don't give, and then 28. So that is what the modified, what we call updated Thai Red Cross schedule. That is what is being given 22202. 2 ID doses on single date on 2 deltoid regions on 037 and 28. So that is what is being done. That this dispensaries has been identified. Like in Chandigarh, I can tell you that 19 sector and 38 dispensaries are identified for this. And in Mohali, the phase 6 Mohali hospital is identified. And in Panchkula, the sector 6 hospital is identified. So these things are available there. So when you go there, they charge for each vaccine dose, they charge 100 rupees. And for giving this immunoglobulin, they use equine immunoglobulin, they charge 50 rupees. So that is available there. This we don't use. And that is what the WHO is saying, that to take out the last dose from this also. So this is 037 only, but on 2 sites. So they have reduced 1 dose, but that is not being practiced in the government setup yet. The WHO new guidelines are yet to be rectified by the government. Pre-exposure prophylaxis, we know that 3 doses, 0, 7, 28. That was previously we believed. Either use intramuscular or intradermal. Okay, so that is what was being followed. The WHO now says you take out the 3rd dose also. So 0, 7, 28, 3 doses, IM route. And 0, 7 is the recent WHO. The pre-exposure prophylaxis, intradermal, again, you can use these 3 doses, 1 site. And now revised is the 0, 7. So the last dose also they have taken. In general, what we need to understand, the first 3 doses, 0, 3, 7. These are actually the primary schedule, which is needed for getting immune response. After that, the rest of the things are boosters. So that is something you can think of omitting or what. That is the reason for decreasing 1 dose in the government schedule, probably. What is Zagreb's protocol for rabies PEP prophylaxis? That is something, if you don't have immunoglobulins available, can you use higher dose of vaccine to take care of this vaccine? So this is what is recommended. You can use double dose for the first day. So if RIG is not available in category 3 bite, then first dose of the vaccine can be doubled or tripled. Zagreb protocol can be followed in immunocompromised, chronic illness, severe malnutrition. Rationale is to increase antigen load, anticipating an early antibody response. So that is what the basis of that. But I think that is not very formally recommended, because the immunoglobulins or this monoclonal antibodies is not actually a replacement for this. Okay, immunoglobulins, like this is the one, the human, the safe 20 IU per kg, human origin, and equine 40 units per dose. So that is there in the government setups. Mostly they are using equine, and this is usually used in the private setups because of fear of reactions. But one of my colleague who is working in a government setup, he told me that hardly they have seen any reaction with this equine. So they are very confident in using equine, and the cost difference is huge in both of them. For adult, this is something around 28,000, 60 kg, and this will be something around 900 rupees. So that is one. Monoclonal antibodies, these both are available now, Rabies Shield and this Twin Rap. And this is dose is 3.33 IU per kg, and those here is 40 units per kg. So which one to use? Anyone can be used, but this is, I think, which one is cheaper you should use. I think this is slightly costlier compared to this. And second thing, this is murine origin, so maybe repeating the dose may be an issue, but that is not an issue with this the rabies shield. This is being used in private sector a lot. So these are the vaccines. Both of them are available now. This monoclonal antibodies. If both immunoglobulins and monoclonal antibodies are available, what should I use? So in that case, whatever data we have, we need to see. So data we have is that non-inferiority trials are there compared to human immunoglobulins. So monoclonal has been shown non-inferior to human immunoglobulin. And secondly, the monoclonal, these for human, you need human volunteers for producing this. Equine, you need horses. And monoclonal you can produce in lab any number of amount. So when these can be produced in the lab, why to go for this using this older procedure? So actually this is unethical to use human or equine if the monoclonal antibodies are available and if the cost goes much down. That is the one logic. And you need to use smaller dose. And this is also much economic compared to the other one. So they say that human one to be preferred in the private setup. That is what they say. WHO and expert opinion, monoclonal antibodies to be preferred over human because non-human source produced by recombinant DNA technology, large scale standard protection assured, less costly, and the more important is it is available. Availability was the main issue earlier. You can purchase, it's available in the market easily. Earlier, the immunoglobulins were not given because they were not available. So that is the biggest plus point for the monoclonal antibodies. 50 kg child with class 3 deep bite of 0.5, so a very small bite. A big child, but a small bite. HRIG still remaining in the syringe, what to do? So should I throw that vaccine or give it intramuscular or what? Or in the locally we infiltrate such a small wound? So the message is the dose, whatever dose is required, you should not give more than that first thing, because that could neutralize the antibody if you give higher doses. And secondly, you don't give it intramuscular to other places because now the studies have showed whatever you have to give locally. The titers given intramuscularly doesn't reach enough to the site. So we don't need to give other site. So as per the recent guidelines, only local infiltration of immunoglobulins to be done, maximum as much as possible. Injecting remaining or giving half of the volume IM, half infiltration is no longer recommended. So that is the message. So remaining one, if you have to use, you can use for the other person. As per the weight criteria, 2 vials of immunoglobulin were purchased. Through the requirement was 1.5 vial. Instead of throwing away the costly IG, can it be given? It can be given to the other person. So the excess use of immunoglobulin more than dose, it will interfere with the antibody response of the vaccine. So should not be done. In a setup receiving many beneficiaries in single days, it can be divided in aliquots in syringes under strict asepsis precautions and used in different patients on the same day. Any remaining immunoglobulin to be discarded at the end of the session. Availability of many strength of formulation in the product will be beneficial to choose in office practice. Okay, a 5 kg infant has a big wound, clean lacerated wound due to dog bite. So a very big wound of around 10 centimeter length. The dose is too less for the infant. What to do? So you can dilute it in normal saline, at least up to 2 to 3 times easily. And if it's much bigger than even up to 10 times, you can dilute that dose with the normal saline and infiltrate in the local site. So make it 2 to 3 times of the volume at least, and even more than can be infiltrated in and around the wound. Okay, 5 kg infant has a big, clean, lacerated wound due to dog bite of 10 centimeter length. Is the bleeding profusely from this wound? What advice to be given? So you're asking basically whether to suture that or not. Suturing is an issue because you can damage the nerves and the risk of having rabies increases. That is the one. But sometimes the wound is so big that you need to suture. So what we advise that infiltrate the wound first with the immunoglobulin. Then after a few minutes, possibly you can give minimal suturing. That is what is recommended. Give some time after this giving the immunoglobulin and then think what minimum suturing is required. Loose suturing can be taken to achieve hemostasis in rare circumstances if excessive bleeding is there and if it is not getting controlled by simple measures like pressure on the wound. Immunoglobulins was not available on day of the bite. What advice? To give it as early as possible. At least up to 7 days you can give. After 7 days, there is no use because vaccine will start working by that time. So thorough wound washing, rabies vaccine prophylaxis should be started. Immunoglobulins can be administered till 7 days after administering the first dose of vaccine. Only vaccine with thorough wound washing will also be effective in 99% of cases. I have received pre-exposure prophylaxis, but always get some scratches, bite here and there on regular basis. Why my pet dog? What action is needed? So what they say is that if you have taken pre-exposure prophylaxis, at least till 3 months, the titers remains very high. So you don't need to take this vaccine again up to 3 months. But after 3 months, if there are scratches and bites, then you can take 2 doses of vaccine, 0 and 3. And no immunoglobulins required. That is what they recommend. Up to 3 months, no vaccine required. After that, 2 doses. Who had taken pre-exposure prophylaxis in the past, immunoglobulins are not required. That is the biggest plus point of taking pre-exposure prophylaxis. But the high dog trainers, multiple dog handlers, these are the people who are a very high risk of developing rabies. So should they take regular boosters or what? So they advise you get your titers every 5 yearly. And if titers are low, you take boosters or you take 1 dose of this every 5 yearly. That is what. But for the general public, people, probably this recommendation of taking every 5 yearly booster is not there. So even after 10 years, if you had a bite and you have taken pre-exposure prophylaxis, you only have to take 0.3. So that is what the recommendation are there currently. What rabies prophylaxis would you advise to an individual who drank milk of rabies cow by mistake? So these questions often keep on coming. So we should know that the milk does not have a high concentration of rabies virus as such, because it's more of a neurotropic virus, one thing. And second thing, the acid is there in the stomach, which will digest. So I don't think there is any recommendation of using rabies vaccine for after drinking milk from a rabid cow, as far as the book knowledge says. So no documentation of rabies transmission by this mode. So there is no need for taking treatment or prophylaxis. I came into contact with blood of rabies dogs. So blood does not carry rabies virus. So there is no viremia as such in rabies. So probably is not required. Vaccine is not required. Rabies is not transmitted by contact or blood of infected humans. But those who are handling rabies patients should always take pre-exposure prophylaxis. The concentration, highest concentration are in the saliva, CSF, urine, and tears. They are probably more infective material compared to this blood for transmission. After receiving rabies vaccine, patient develop rash on the whole body. How to complete this series? So actually, a rash is not anaphylaxis. No, we will be having this talk coming time when we call anaphylaxis. But even if there is a rash, we have to complete the vaccination schedule because rabies is life-threatening. Only option you have is that you may change the brand, different brand you can use. And that is what you can do. And remain alert for managing anaphylaxis if that develops. So further doses need to be given under supervision. And if allergy is there, then you can change the brand. After giving 2 doses of rabies vaccine, the brand which was used is out of stock. What to do? So again, the same rules goes with other vaccines. If the same brand is available, use that. If that is not available, use other brand, because that is better than not using vaccine. That is what you can do. Whatever is available, interchange is allowed in such situations. Okay, child has approached 10 months after dog bite. On local examination, scar mark is visible. So recently I had a talk on radio. So then some police person was there. He was asking me that I am now 60 years old. बचपन में मुझे कुत्ते ने काटा था जब मैं 5 साल का था, और अभी भी मुझे रात को सपना आता है कि वो कुत्ता मुझे काटने तो नहीं आ जाएगा, कहीं मुझे रेबीज तो नहीं हो जाएगा। तो क्या मुझे अभी रेबीज वैक्सीन ले लेना चाहिए? I think that the type of questions keep on coming now. So you need to understand that 99% of rabies occurs within first 6 months of bite. 99% of rabies occurs within first 6 months of bite. After 1 year, chances of having rabies are less than 1%. This is what we know by the statistics. So what should we do? So vaccination probably you can give any time. At least up to 1 year vaccination should be offered. How long the immunoglobulin to be given? Immunoglobulin has a role till the scar is there. No, till the wound is there. If the wound has healed, how much the immunoglobulin will help? But still some people feel that up to 1 year they give immunoglobulin. But I don't think the justification is there for giving immunoglobulin once the wound has healed up. So that is what I personally feel. So that you can follow. Can we use intradermal regimen office? Definitely intradermally when you are using dose preserving strategy. No, so if there are more doses you have to give, you use intradermal because you can use it for other patients. In office practice, what will you do with the remaining dose because you don't have them that much of patients. So that is primarily where the multiple patients are being seen like it, and that is why it is practiced in the government setups primarily. And better will be to stick to the this intramuscular regimen in the office practice. However, there is data to say that intradermal and this intramuscular or intradermal is non-inferior to intramuscular. So you don't feel that is much better or much lesser, but both are equally effective. But there's no logic of using intradermal in office practice probably. So they are comparable, and DCGI has given permission to follow company brands where single dose vials can be used for giving ID injection. Okay, but in setups where beneficiaries are very less, there will be no use of saving the vaccine. So IM is preferable. Giving ID injection is skill, and then you should be how to give intradermal. Many of the people may not even know that. So that is another issue. So rabies is a fatal disease. There is no scope of human errors while giving this vaccine. These are the vaccines which are available in market, common vaccines. You can see these vaccines are there, and these are commonly used. I think with this, I've come to the end of the presentation, and we'll be more than happy to take questions.
Thank you, sir. Will you take the questions of these two vaccines first, or we want to continue with the next?
First, continue the HPV vaccine, then we'll take questions.
Okay. Dr. Mehta, he's online.
Yes. Good afternoon.
Good afternoon, sir. Please introduce, sir. Dr. Sashikant is here. Please introduce, and then we'll start with the.
Sure.
Good afternoon.
Welcome, Dr. Shashikant.
Hello.
Good to see you. Dr. Shashi is professor and head in Department of Pediatrics, GGS Medical College, Faridkot. He has done his MD Pediatrics from Jaipur, SMS, very prestigious college. He has done his IP fellowship in neurology from Khartoum Medical College. Hello, can you hear me?
Yes.
Yeah, audible.
He has done his DMD in neurology from PGI. He has won a number of awards and honors in the form of Indira Gyani Award by AAP, American Academy. He got his SS Manchanda Neurology Research Board Merit Awardee, Best Graduate Award, National Best CC Award. He is also convener in IAP AC's VIP, and is a national faculty of NRP. He has various publications to his name, chapters in books, national international presentations, and is a resource person in national and regional conferences. I welcome Dr. Shashi to start his talk.
Thank you. Good evening, good afternoon. Good afternoon, everyone. Thank you, Sagar sir and other office bearers of the IAP for having invited me on this prestigious forum. So I'll share the screen now. So is my screen visible?
Yes.
Fine. So I'll just give me a sec. So slideshow. Is not going now. Yeah. Okay. So in next around 25 minutes or so, I'll be discussing about human papillomavirus vaccine. So it's a very pertinent vaccine currently being used in a more incidence as compared to earlier ones. So if we see about the composition of the HPV vaccines, so there are two traditional vaccines. One was Gardasil and second is Cervarix. So HPV types, the serotypes, these are HPV-4 vaccines, this is Gardasil, and HPV-2 was Cervarix. So serotypes 6, 11, 16, and 18 were covered in Gardasil, and it had 20, 40, 40, and 20 microgram per dose of antigen of each one of them. And technology used to prepare this was yeast proprietary assembly, and this reassembly process which required increased stability. So adjuvant which was used was 225 microgram of amorphous aluminum hydroxyphosphate sulfate in Gardasil. So if we talk about Cervarix, it contained 16 and 18 serotypes. So in the composition of 2020, it was an insect cell substrate vaccine and had adjuvant of aluminum hydroxide and deacylated monophosphoryl A as the adjuvant. So in addition to this, so this 6 and 11 serotype were extra in this. So nowadays, the 9-valent HPV has come. So in this 9-valent HPV, 5 new serotypes have been added. So which are 31, 33, 45, 52, and 58. So the percentage of this ammonium hydroxide sulfate is also increased to double. Now it is 500 microgram as compared to 225 microgram. So this is basically the difference between 9-valent HPV and the 4-valent HPV being made by same company, right? So this is just a snapshot of the common vaccines which are available. And nowadays a new Indian kid on block has also come from Serum Institute of India, that is Cervarix. So these 4 brands were or are available. Out of this, Cervarix is not available these days. So what is the schedule of these vaccines? So if we talk about the first vaccine or the initial vaccine, which was HPV-4 vaccine, the Gardasil 4, the schedule was the 2 doses were to be given between 9 to 14 years of age. So if the age of the person is more than 14 years, we used to give 3 doses. And this Gardasil 4 was not licensed to be given in males in India. So in comparison to that, the latest vaccine, which is about to be rolled out by probably Government of India, the Cervarix, this dose is similar to that of HPV-4 vaccine, 2 doses. But if the age is more than 14 and less than 26, between 15 to 26, if it is a female, then it recommends 3 doses. So in males also, it recommends the doses can be given similar to that, 2 doses between 9 to 14 years of age and 3 doses between 15 to 26 years of age. Now, if we talk about the HPV 9-valent vaccine, so it again tells us that the 2 doses are to be given between 9 to 14 years of age if it is a female. And if the age is less than 26 and above 14, then 3 doses are to be given. So this vaccine, in comparison to HPV-4, is licensed to be given in boys also. And the licensing is present only between 9 to 14 years of age. The once Cervarix, which was frequently available, currently is not available in Indian markets, and the doses was similar to that, the bivalent dose, 2 doses and 3 doses, and this was not licensed in males. So once again, this. So one important thing is that this SAGE committee, it has recommended single dose of HPV vaccines only. And so WHO says that only single dose of vaccine of HPV is sufficient or non-inferior to others. So its important question comes, should we use a single dose of HPV vaccine in our practice? Would it be equally effective? So it's a very pertinent question. So many of us, many of IAP members do come around with this question only. WHO says give 1 dose. Why we are insisting on 2 doses? So my dear friends, the answer to this is the WHO vaccination dosage of single dose was based on efficacy studies which were done in low income countries, like Kenya study was there, Costa Rica studies were there, IRC India studies was there, Doris Tanzania studies were there. So if we want to see the feasibility of single dose, it was contemplated, it was taken up because the overall vaccine coverage in those countries was very less. So just to ensure that at least one dose is given for this important vaccine, which will cover so many carcinomas in females as well as males. So just to increase the target vaccination coverage of more than 90% to all girls, the WHO has recommended giving the one dose of the vaccine only. But this will be only be programmatically convenient. But having said that, if we see that will it be equally efficacious if we give 2 doses? So the exact titers of the effect of 2 doses versus 1 dose, and the studies in boys as well as studies in immunocompromised patients as well as the older women, they are still not very much available. And it has been seen that the 2 doses provide a more long-lasting effect as compared to a single dose. Therefore, if at all we, as of now, give single dose of HPV vaccine as recommended by WHO, we would be giving only an off-label dose and not the best available dosage which is recommended for this vaccine, right? So let's discuss few of the important scenarios which the patients which will be coming, the relatives which will be coming to us will be able to see. Right? So if a 15-year-old girl comes to our clinic for not gaining weight and general checkup, that this side has come for something else, and during the conversation we advise HPV vaccine. Mother wants to tell that she will take the vaccine after the marriage of the girl. What to do and why? So that's an important thing. So mothers commonly ask, "Abhi to hमें नहीं देना, हम तो शादी के बाद लगाएंगे, तब ज़्यादा chances है." So what should we do and why? So is it slides are not moving? Okay, so we should all understand that this vaccine is a prophylactic vaccine. Therefore, ideally, it has to be administered before the exposure to the sexual contact. So there are 2 reasons. One is sexual contact is very unlikely in the 9 to 14 years of age group. Plus there is denuded the epithelium. So while counseling, we should not use in India the words of this sexual contact and all, because it is very unlikely that the girls of this age would be having the sexual contact and parents might feel offended. So we should use some words like epithelium abrasion or something before that. So we should tell them as early as possible after 9 years, this vaccine should be given to have long-lasting effect. And we give Tdap at 10 years and we can club this vaccine with the existing Tdap schedule in our ACVIP guidelines. And we can also, and we should also tell that immune response is always better when it is given between 9 to 14 years of age. And we should also tell one additional advantage, that is that once we give the vaccine between 9 to 14 years, we have to give only 2 vaccines and not the 3 vaccines as required after 15 years of age. So therefore, during this period, we have to tell them the reduced cost, the prophylactic type nature of the vaccine, the better immune response, and we should also tell that vaccination given at this age gives same titers. This is a non-inferiority response to the 3 doses, and that's why it is equally efficacious. And we should also tell if we give more vaccines to the girls, then it will provide herd protection for the boys as well, right? So we should try our level best that if at all we want to give HPV vaccine, we should give between 9 to 14 years of age. This is coming to a second scenario. A girl comes that her mother is 35 years of age and she's sexually active, that comes for HPV vaccine. What is your advice? So now the age of the mother is 35 years, and how would we advise such patients? So we have to understand that this is a catch-up vaccination because the primary schedule has been mixed. So we have to explain to our patients that the catch-up vaccination could definitely prevent by vaccine types to which women has not been exposed. There are chances that out of the 9 or the 4 serotypes of women has been exposed to the other HPV serotypes. But the serotypes which the mother has not been exposed, they could provide. This vaccine will be preventing infection in that. And it is important that once the immunity occurs only to one serotype only, it does not give cross protection to the other serotypes. And it is type specific, and that too not absolute. The natural infection which occurs by the course of nature, it's not fully optimal and it gives only suboptimal immunity. And we should also understand that vaccine given to this age then lead to neutralization of virus which is shed into the cervical vaginal canal from the prevalent infection, and it will also lead to herd immunity. But it is important to decide that these women will be requiring 3 vaccines, and therefore high vaccine cost will be involved. And also, we should always remember that India is one of the most important countries where HPV disease, the disease caused by HPV virus, are very common. And unfortunately, the screening practices in India are not performed routinely. Therefore, whatever disease we get around 7 lakh cases of CA cervix per year, and most of them are present in high stages or terminal stages. The only reason is because they are clinically detected or suboptimally detected later. Therefore, screening practices should always be strengthened if we want to decrease the morbidity of this disease, right? Now, coming to one more scenario. If we have a 12-year-old child who has received 2 doses of HPV series 2 months apart, according to the 2-dose schedule. So we should see that this injections have been given early, right? So is her HPV vaccine series complete, or does she need a 3rd dose? So it's a very pertinent question most of the times. Sometimes the patient, instead of 3 doses, gets 2 doses. They think that in 9 to 14 years of age, we need 3 doses. But as per her age, the baby requires 2 doses. So they give 0-2 or 0-1 schedule of the vaccine. So is this schedule complete, or does she need a 3rd dose? So it is important to understand that if the children who are between 9 to 14 years of age, who have received 2 doses of HPV vaccine, which are separated by less than 5 months, should receive a 3rd dose 6 to 12 months after dose 1. And at least 12 weeks after dose 2. So therefore, the duration between the 2nd and the 3rd dose should be 5 months, and at least 12 weeks should elapse between dose 2 and dose 3, right? So it's important to note the differences required between the two. So another scenario, a 12-year-old comes after 1.5 years for 2nd dose. Should we restart the schedule? So contrary to the last question, last scenario, in that the girl has received premature vaccination. So in this, the girl is receiving delayed vaccination. So what we should do in this schedule? So we only complete the schedule with 2nd dose now. We do not restart the regimen over and above again. So only single more dose is required to complete the schedule. And this is again very important thing. If a girl is primed before 15 years of age, so 1st dose given before 15 years of age, and then also the 2nd dose, single dose is required, even if the girl comes late. So age of 1st dose is very important. So next question, do I need to worry about HPV disease if my boyfriend, I always use a condom, right? So this is also a very common scenario. People insist that they're using adequate protection, but still do we need this HPV vaccine? So if the male partner has got an HPV infection, even if that person is asymptomatic, the female partner can still be infected with HPV, even if the boy uses the condom. So this is for the 2 reasons. First, containing the virus. So the female partner could be infected and still get this. And second is, it could also be transmitted during other forms of sex, like oral sex or during genital to genital skin contact. So therefore, it is important to know that even if the boys are using condom, HPV vaccine will still provide adequate protection, right? Okay. So just in case we are giving the HPV vaccine, which is to be given intramuscular, but by mistake, the dose is given subcutaneously. Would we consider this dose a valid dose? So the answer is no. We have to repeat the last dose by intramuscular route only, right? Okay. So next, by chance, a pregnant lady is administered the vaccine. What is to be done? So what is to be done in this? So there's no evidence as of now to tell that this will harm the fetus. So in that case, we continue the pregnancy and we do not give the second dose then, but we give second and third dose after the delivery. So during the delivery, whatever dose has been given, we stop at that and we give the remaining doses after the delivery of the lady. The next, a 12-year-old girls comes with HIV. So should we give 2 doses or 3 doses? So girls which are immunocompromised, we should remember that those girls, the special circumstances, will be dealing about such kind of things later on. They require complete schedule. In this case, 3 doses would be advised. So in all the immunocompromised patients, 3 doses are to be given. So now coming to next question. So if our patients have received complete series with bivalent or quadrivalent vaccine. Now the 9-valent vaccine has come. So patients come to us that should we repeat the vaccines or should we forget about it? So the answer to this is we should not revaccinate those kids. So the patients who have been given already been given the HPV2 or HPV4, that one is fine, and we do not need to add another vaccine for the HPV9. But if someone demands that we need this extra protection against other serotypes that are included in it, then we have to give the vaccine. So suppose the extra serotypes are being demanded by any parents for their children, then we can give the age appropriate whole series again, and all the 3 doses and or the age appropriate dose is to be given, right? So this is about this. Then next case is a parent wants this vaccine to be administered to his 13-year-old son. Now coming to boys. So will we vaccinate the boy too? And if yes, which vaccine? So DCGI currently approves this 9-valent HPV vaccine for the males also. The serum vaccine is also DCGI approved for males. So we can give this HPV9 vaccine or the Sarvavac vaccine to the boys. The older vaccine, which is HPV2 and HPV4, they did not have a DCGI approval for males in India, right? So the reason of giving to the boys is that there are many other type of cancers, malignancies, which are being decreased by this HPV vaccine. So I'll be discussing about those later. So it is useful in both the sexes, the males as well as females. So these are the common vaccines. These are what I was talking about. So a full complete schedule of HPV vaccine protects around 100%, and it gives long-lasting immunity against CA cervix. For penile cancer, it decreases around 45% of the penile cancers, 35 to 40% of the oropharyngeal cancers, the vaginal cancer around 60 to 90%, the vulvar cancer of around 40%, and genital warts 100%, and also anal cancer of around 80%. So there is much more than a CA cervix which is being offered by this an important vaccine. So the time has come that boys should also be offered this vaccine, especially the 9-valent and the Sarvavac vaccine, which has been approved by DCGI. So I think this was all about the HPV vaccine. So should we discuss about these newer vaccines now, sir?
Yeah, in short.
Okay, fine. I'll just touch.
Just a passing reference in 7 to 8 minutes will be enough.
Fine. Okay, thank you. So coming to the few of the newer vaccines and the COVID vaccines. So the Shingrix vaccine is present. It is available against zoster. So it is genetically engineered protein, glycoprotein E adjuvanted with ASO1B. So this is given 2 doses intramuscular 0.5 ml 2 to 6 months apart. This is not a live vaccine and usually used more than 50 years of age, and irrespective of the prior receipt of varicella or zoster vaccine. So it also provides immune response for around 15 years. So it has around 97% of the immunity against herpes zoster. This vaccine is available. So this is Shingrix vaccine. Now coming to vaccine against mosquito, Mosquirix vaccine. So this is RTS-AS01 based on circumsporosite protein. So this is a recombinant chimeric virus-like particles which acts in the pre-erythrocyte stage. So it protects against only falciparum malaria, and 4 doses are given, 0.5 ml dose given intramuscularly. So 3 doses are given between 5 months to 9 months, and booster doses are also given later on. So this vaccine is commonly recommended these days in regions which have got moderate to high falciparum malaria transmission. But efficacy is also around 40% only. So it is not effective against Vivax, and efficacy is only 40%. So it will not be cost effective in low transmission zones, right? So coming to dengue virus, dengue vaccine. So this is live attenuated recombinant tetravalent dengue vaccine. So again, 2 doses, 3 months apart, giving subcutaneously. So again, there is no evidence of disease enhancement noted and no serious adverse effect. 61.2% against confirmed dengue cases and 84.1% against very severe dengue cases. So this vaccine is likely later will be in due course of time given in Indian population also. So coming to RSV vaccine, so prevention of lower respiratory tract disease by RSV. So usually recommended in elderly more than 60 or the patients who have got comorbidities. So single dose is required, and very severe low respiratory tract infection is decreased by 82%. So this has also received FDA approval. Another vaccine for RSV is this vaccine by Pfizer is used in infants less than 6 months. Also in pregnant women if the gestation is between 32 to 36 weeks. So in European countries, this vaccine has got approval for elderly population also, single dose 0.5 ml, and this also reduces the incidence of severe disease. And TH rabies vaccine. So this is rabies vaccine for adults only. So 3 doses only are recommended, 037. So it is approved by DCGI in children which are more than 18 years of age, right? So TH rabies. And coming to now important COVID vaccine. So I'll not go into more details, but a whole load of type of vaccines are available. There is inactivated whole cell vaccines, that Covaxin is there, Sinovac is there, Sinopharm is there, Chinese vaccine and Indian vaccine both. Live attenuated vaccine are also there, that is Codagenix vaccine, nasal vaccine. Vector-borne viruses are also there, like Covishield was there, Sputnik was there, subunit vaccine like Covovax was there, Covivax was there. Nucleic acid dependent vaccines are also there, Moderna vaccine, that Pfizer, Comirnaty, Zemcovac 9, Zemcovac OM, Zycov-D. In addition to that, other vaccines are also there. So huge list of vaccines were developed during the COVID era, and they are available right now. So in those, the which are available in India. So the first one is recombinant chimpanzee adenovector virus vaccine, 2 doses given intramuscular 4 to 12 weeks apart with 81% efficacy. Then Covaxin, which was again, we all have gone through a lot of these details. So Covaxin was available, Covishield was available, so Sputnik 5 was available, and Zycov-D was available. So as of now, the COVID vaccine, the disease is comparatively on the ebb side. So a lot of vaccines have still come in the market. Then another protein subunit vaccine, which is delivered with Texas Children's Hospital, 2 doses, 0.5 ml, effectiveness more than 80% against Delta strain. Then Covovax from Serum Institute of India. It has a subunit protein-based recombinant vaccine, efficacy of 96% against original strain, 86% against alpha, and overall around 90% of the efficacy was there. Another vaccine was Zemcovac 19, the first Indian mRNA vaccine was there. So Incovac from Bharat Biotech vaccine, this was an intranasal vaccine. Total 8 drops were given to be given in adult age more than 18 years of age. So this also was a special vaccine because it blocked both infection as well as transmission, right? So Zemcovac OM was made from Pune against Omicron variant. This also vaccine received EULA in June this year from DCGI. So it is an mRNA vaccine, and 2 doses schedule are given above 18 years. So commonly we do not use these in pediatric population. So coming to recent updates. So present vaccines were not very effective against Omicron strains, and newer circulating mutated strains, still we require those vaccines to cover the currently mutated strains. The bivalent strains containing Omicron plus original strain is the need of the time. And God forbid, this COVID should not strike again in the same propensity as earlier. So we may never require such kind of vaccines against. And just in case it comes, multivalent vaccines are also being studied upon. And there have been various combination vaccines in which flu vaccines and this COVID vaccines are combined together, and they are being thought of, right? So different efficacy data are available for different studies around the world, which is the best one, right? So as per WHO, since the vaccines were fast-tracked, so the benchmark was set at 50% of the efficacy. So WHO says if a COVID vaccine is 50% efficacious, they'll label this as efficacious. So all vaccines are actually giving 95 to 100% against severe COVID and death. And boosters will further increase the neutralizing antibody titer many-fold. So this is the present status of these. So as of now, is there any correlate of the protection established? So no correlate of protection established has been present till now. So vaccines give both B and T cell immunity. So as of now, number of studies, the boosters required, duration of protection. So these need currently more studies to be more specific of the answers which are still not present, right? So Covaxin has received the emergency use authorization above age of 6 years. The Corbevax above 5 years, the Covovax between 11 to 17 years, Zycov-D 12 years. Covishield as of now is not used in children, and because the studies were present only after 18 years of age. So in Western countries, Moderna and Pfizer mRNA vaccines are commonly used above 6 months of age. So these are the common vaccines which are available against COVID. So these are the vaccines. So I end here, and over to you, Vinit sir and Dhuria sir.
Thank you, Dr. Shashif, for an excellent presentation and increasing our knowledge. Can we take questions? Few questions?
Yeah, please go ahead. Only one thing which I would like to add, that ABRY SVO vaccine, RSV, is to be given in pregnant women in the similar way we give Tdap to pregnant women. So Tdap is given in pregnant women to protect the infants from neonatal pertussis. Similarly, ABRV SVO vaccine is given to pregnant women to protect the infants under the age of 6 months, but it is not given to infants as of yet.
I have a question for Dr. Sanjay Verma. Dr. Sanjay?
Yes, sir. Yes, sir.
You said that in case of some severe white layer neck and head, we can give 2 or 3 doses of vaccine to just potentiate the effect of the vaccine to make early antibodies. Am I right?
No, that was something which when immunoglobulins are not available, that was the point.
Okay. In case we have a child who has a lot of bites and like he's not cooperative to give some infiltration around the wound. So in that children, can we use double the dose of vaccine?
So like I said, that is as a replacement of that was, this was that situation when that is not available. But I don't think immunoglobulin has a replacement. I don't think we should not attempt those things. No, the whatever the crying or whatever, immunoglobulins are life-saving. So I don't think we should replace immunoglobulins with this double dose technique. No, that is only somewhere where there is no option available. And that's it. You can try, but this is not a foolproof thing.
Can I answer something? Can I make a comment on this? Actually, such patients should be admitted, and under sedation also immunoglobulin can be given from the local side. Rather, advising a replacement of the globulin was a very risky proposition. And if somebody
the
goes
only
wrong,
thing
it's a
that
very
was not,
medical.
because in government setup also the immunoglobulins were short some times back. And in private, in those days when monoclonal antibodies were not available, the human was very, very costly. So people were not able to afford it to purchase it. So these thoughts of Zagreb protocol were basically at that time. Now monoclonal is also very cheap. So I don't think there is any issue. In government setup also immunoglobulin is very freely available. So that is just a theoretical part, the Zagreb protocol.
One more question, Dr. Sanjay.
Yes, sir.
If the one child has received full course of post-extra prophylaxis, you said that 3 months period is a time we should not give the vaccine again. That booster part 0 and 3.
Yeah, that is what, because some studies are there which are saying that up to 3 months the titers remains very high. So there is no added advantage of giving boosters at that time. But after that, the titers start falling. So that is the stage the boosters have a role. So that is what I mean. So after 3 months, if there is a bite, then it's role of giving additional doses of 0 and 3.
So if the child comes at 4 or 5 months, we should give the 0 and 3 dose.
Yes.
Okay, thank you.
Sir, question from my side. What is your advice for the people who are fond of pets?
Like I said, those who have pets, I said no, either you have children or you have pets. You don't have both. If you are going to have both, then give pre-exposure prophylaxis to both of them. I think that is what we advise. So pre-exposure prophylaxis should be liberally practiced actually. So first bite or first scratch should be taken an opportunity to give that post-exposure prophylaxis. That will work as a pre-exposure prophylaxis as well, if not taken in past. But if you are planning to have a pet, then better will be to give pre-exposure prophylaxis, because risk of developing rabies in children is very high. And secondly, that question keep on coming, that if the pet is biting almost daily, then what to do? No, that kind of situation is there. So take pre-exposure prophylaxis, both you and the pet, both should take. And then if the bite is that not significant, then you need to see that how much is the risk, no? From where this dog will get the rabies, with contact with the other dogs. So if you are 100% sure that dog is there with you all the time, and you have both have taken prophylaxis, the risk of developing rabies is actually very less. But if the bite is significant, it will be better to take 0-3 dose.
Sir, just in
every
like
3 months, all the pet lovers should take booster.
If there is a scratch.
If bite is so often.
Sir, just one.
Scratches are often.
Sir,
Scratches are often, sir.
Sanjay sir,
Yeah.
we should
Sir.
modify this sentence to we should have either vaccinated children or pets instead of children.
Okay.
Either we should have vaccinated children or pets, but not both.
Yeah, that can be done.
Actually, most of the people have pets because of their children only. They are not in the mood because they already know how much fuss is there with the children themselves.
Yes,
Animal
you are
rights
correct.
people might be, the animal rights people might jump at this statement, that you don't have pets.
Yeah. And
one thing
I'm
I would
saying
like
that
to
you
add,
have both, but both vaccinated. That is what I'm
yes,
saying.
both should be vaccinated, and
Yes.
even if you give good quality vaccines to dogs, the maximum efficacy which is achievable hardly 60%.
yes.
So that is why we don't rely on the vaccination of dogs. We rely on vaccination of humans only.
So this
The
this
statement
current
would be to vaccinate every 3 months, 2 doses, or 1 dose every 6 months.
Pardon me, I couldn't hear you.
Now, the statement to be issued would be to get 2 booster doses every 3 months or 1 dose every 6 months.
No, as far as boosters is concerned, if you have taken a full PREP or PEP, in a case where you are not a very serious dog handler, like multiple dog handler or zookeeper, forest keeper, you are supposed to take a booster every 5 years. Every 5 years. But if you are a dog trainer, zookeeper, forest keeper, veterinarian, in those cases you have to take booster every 1 year, or you have an option of checking your antibodies level. If the antibody levels are above 0.5, then there is no need to take booster, but then you will have to check antibody titer every year.
Thank you.
Dr.
Sanjay
Sagar,
sir,
I have
how to
a
manage-
question to this.
Yeah.
Sorry.
How to
you
manage
ask?
when the wound is on fingers or the ear? The infiltration becomes very difficult.
But
Both.
we have to infiltrate as much as possible.
and
Can't help it. We have to infiltrate.
even
The
risk
tricky
is
part
always
is when there is no wound, like on mucosa,
conjunctiva.
and you want to do it. So then what to do? That is the most tricky part. Dr. Sanjay, question for you. So there was a contact of saliva with the mouth of a child, what to do?
Saliva with the mouth of a child. So saliva coming in contact with the mouth of the child.
Yeah.
That is what you are saying, no?
Yeah.
So that is actually coming into the category 3 definition. If you go by the definition, they say the saliva coming in contact with the mucous membrane is a category 3 wound actually.
So what to do about immunoglobulin now?
So if the pre-exposure prophylaxis has been taken, then no immunoglobulin is required. But
And
if
if
not
not,
taken, then possibly you need to infiltrate there.
Where to infiltrate? There is no wound.
We have to rinse. We have to just squish. So we can dissolve the immunoglobulin into normal saline, then we can do gargles or something like that. So that will be the first. Even we can rinse the conjunctiva for that also.
Yes, yes, that can be done.
Dr. Sanjay, I have a question. What is the time period if we get a full dose of post-exposure prophylaxis? Five doses we get. Up to 5 years, we need to take boosters, or up to 3 years?
So like Dr. Sagar was saying that as such for general population or general public, there is no recommendation to take regular boosters. But for higher risk population who are having very high risk of having rabies or coming in contact with unvaccinated people, unvaccinated dogs, like dog handlers or handling the viruses, they are supposed to keep a check on their titers or take every 5-yearly booster. A routine booster recommendation for those who are having pets is not recommended as such. There's no recommendation for routine booster. So if you have taken pre-exposure prophylaxis, then even after 8 years or 9 years, you get a bite, then you are supposed to take 0.3. That is what is written
up to 5 years or more than that. Up to 5 years.
Even more than that. Even more than that. There is no recommendation for taking regular boosters for general public. So even after 8 years, for 8 years or 10 years or 12 years, if you get a bite and you have taken a pre-exposure prophylaxis, as such, there is no recommendation that you should take every 5-yearly boosters. That is only for those who are at very high risk. But if you are very much worried and you are thinking that you want to take, there is no harm in taking a booster. That is a different thing. But as such, there is no recommendation to take every 5-yearly booster for general population or general public.
And as far as the protection is concerned, there is no such period for which it is defined, but generally it is said the protection will last for 15 to 20 years definitely.
Okay.
Dr. Sanjay, can I put a question to you, please?
Yes, sir.
Suppose a child who was bitten by a dog, whether pet or a street dog, completed the 5 doses of immunization that we recommend. And suppose maybe say about 8 months or 10 months or 1 year later was bitten again by a obviously rabid animal. How to proceed in this situation?
So the guidelines go the same. You have completed the post-exposure prophylaxis once. So after 3 months, if you have a bite, you are supposed to take the vaccination. 0.3 you are supposed to take. As such, there is no recommendation to take immunoglobulins in that situation. But if you feel that this is actually a non-rabbit bite is there, then in that case, giving immunoglobulin is no harm as such, because many people feel that immunoglobulins are very effective in preventing rabies. If you know that it's a rabid patient, then giving immunoglobulin is not a contraindication as such. It is only
not a recommendation.
Recommendation
That is not a
recommendation. That is what I'm saying. It is not a recommendation as such. But individual patient, you are saying the rabid patient is there, rabid dog is there, and if that is biting, because immunoglobulins have a direct effect, immediately it will be effective. So many people, like if you have a bite on the tip of this fingers, that has a very high risk of developing rabies. So in that case, you may think of giving, but as such, there is no recommendation. You presume that your antibody levels will be higher and they will be able to take care.
So no standard recommendation to take immunoglobulin. That was a personal thought that yes, one might think of giving it.
I have a question regarding this saliva thing. So it's a so common thing that the kids actually they kiss on the face or the mouth of the pet dog. So do we all these conditions we have to consider them as a class 3 bite?
So if you go
That
by
is the importance of giving PRAP, isn't it?
yeah.
Our children.
Sir, this current recommendation which ACVIP is which is coming, that will include this pre-exposure prophylaxis also. This,
Pre-exposure
yeah,
prophylaxis is actually very important.
it's very
If you
important.
have children at home and dogs, because
Absolutely.
that significantly decreases the risk. Then whether you take pre-exposure prophylaxis or post-exposure prophylaxis or not, that will depend upon how much is the risk you are having with that bite or exposure. No, so saying this is very easy that you take with every bite, but many times this is happening. It's happening multiple times in a day. So actually things are very difficult. So safe will be to take pre-exposure prophylaxis. And then you see if there is significant bite, then definitely you will take those things.
Just one more comment, sir. This purple book is not mentioning, it's already public, is not mentioning whether children having pets should be recommended. They have given this high risk scenario, but they have not mentioning whether children having pet dogs should be giving pre-exposure prophylaxis. Maybe
it has to be given. That is a standard recommendation.
yes. That's what the addendum is.
Yeah, but this now very soon we are coming with this latest recommendation that will be recommending pre-exposure prophylaxis for all children in this coming recommendation.
But will it be followed by government? That will be different.
That's a different issue. But then again, then ACVIP is only for office best practice now. So we should. हम ऐसी ऐसी डिजीज के लिए देते हैं जो हमें होना ही नहीं कभी. डॉग हमारे घर में बैठे हैं, हम उसके लिए नहीं दे रहे. मतलब I mean, it's a different type of thing now.
Let us see how it. I think we can go on to the next lecture. Let two more lectures.
There are a few question answers in chat. In this chat, I can see.
If they're on HPV, please take it.
Yeah. I would like to answer those, sir.
Yeah, please answer.
There are 5 questions. The first question is why HPV should be given in boys. So gone are the days when we thought that this HPV virus is only active against girls. So not only the HPV vaccine acts against CA cervix, but it also is very effective against oral cancers, anal cancers, and penile cancers plus warts. So therefore, these 3 cancers are very common in boys, so should be given to both boys as well as girls. Second question is how HPV-9 is better than HPV-4. So HPV-9 contains 5 extra serotypes which are not being covered in HPV-4. So therefore, the more serotypes are there, the more protection it has. So therefore, it is more beneficial. Then third is if there is a delayed dose, what should be done? As we had reiterated in this session, that if there is a delayed dose, we should not start the full schedule again over, but we should just pick from where it was left and we should continue the completed dose schedule. And then next is if the patient is earlier vaccinated with Cervarix vaccine earlier, what should be done now? So if the patient has been vaccinated with age-appropriate vaccines, then nothing needs to be done. But if the age-appropriate vaccines are not given, then we should complete the age-appropriate schedule for those.
I think may I make one point? This Gardasil 9 is quite expensive, 10,000 rupees,
Yes.
something like that. 2 doses
Yes,
become
yes,
20,000. To
Yes.
convince parents to have the boys receive this, it's a bit of a challenge sometimes. But as you're saying, I mean, we have to see the benefit versus the cost.
Absolutely, sir. Absolutely. This one-to-one discussion has to be done in with the families, and if they are convinced and if they want, then they should be given an option. But not for programmatic reason, not for that. But you are very right, sir. And one more question was there. Yes, other diseases, this have already covered.
That we have discussed.
Yes,
That we have discussed.
I think we can go to next session, sir.
Please go on to the next session.
Thank you, speakers. So I just hand over the next session to Dr. Diljit Singh, who is my teacher also, my mentor also.
Thank you, speakers.
Dr. Gambhir and Dr. Harpreet, please.
For the next session, moderators will be Dr. T.S. Gambhir and Dr. Harpreet Bode. Dr. Gambhir is a senior pediatrician and ex-vice president IAP Punjab. And Dr. Harpreet is a senior pediatrician working at Krishna Hospital, Model Town, Ludhiana. To Dr. Gambhir, please.
Good evening, everyone. We'll have the first session from well-known speaker, Dr. Diljit Singh, who will be speaking on vaccination and special situations. So, a brief detail about Professor Daljit Singh, I would like to share with everyone. He is ex-Vice Chancellor, SGRD, University of Health Sciences, Amritsar, retired Principal and Professor and Head of Pediatrics, DMCH, Ludhiana, and ex-Professor and Head of Pediatrics at CMC, Ludhiana. His areas of interest are medical education, pediatric pulmonology, and infectious diseases. He has held various positions in his glorious career. He was founder, president, intensive care chapter IIP Punjab, president and secretary of Punjab State IIP, president secretary of Punjab branch of NNF, national governing body, member of NNF, executive committee member of Central IIP, and he is fellow of Indian Academy of Pediatrics, National Neonatology Forum, National Academy of Medical Sciences, International Medical Sciences Academy, fellow Foundation of Advancement of International Education and Research at Philadelphia, and visiting fellow RCPCH UK. He has authored 5 books, more than 120 nationals and international publications, and 20 chapters in books. He has given his editorial services to 12 medical journals till date as editor-in-chief and member of editorial board, etc. I would now like to hand over the session to Professor Daljit for his deliberations.
Thank you so much, Dr. Gambhir. It's always a pleasure to be with our fellow colleagues and share some thoughts on important topics. I'll just share the screen. Okay, so this session is on vaccinations in special situations. Well, what do we say is a special situation? It is a situation in which the administration of a vaccine could result in suboptimal efficacy or increase the chances of the adverse events following immunization. So it's a very important area because normally we do talk a lot about the normal routine things which we should follow, but there are many occasions where you have to adapt and change the schedule or the procedure and modify it so that we can maintain the expected efficacy of the vaccine or to prevent the adverse effects. Now, there are some general principles when we talk about vaccines for the immunosuppressed population. 3 questions come to the mind, and we can answer these briefly. First is, which vaccines can be given to children who are immunosuppressed? So the first point is that all inactivated vaccines can be given. Only problem is that the immunogenicity and the efficacy could be lower in those who are immunosuppressed, and therefore you may have to use a higher dose or increased number of doses, and you may have to monitor the seroconversion so that we are able to maintain the protection. And on the other hand, in severe immunodeficiency, all live vaccines are contraindicated. These 2 facts have to be kept in mind throughout when we talk about special situations. In mild or moderate immunodeficiency, sometimes, the situation may be such that the benefit of giving the vaccine outweighs the risk. And so you may make a calculated and a deliberate, informed decision about using a vaccine. So that's one question. The second is how to keep the protection in an immunocompromised person. How do you maintain this protection? There are 3 or 4 points to consider here. Firstly, the household contacts of immune compromised children should not receive transmissible vaccines. For example, a typical example is the oral polio. However, there are some other live vaccines like MMR or varicella, which are not really transmissible and therefore they can be given. And the second point is a cocooning effect strategy should be utilized for protecting the vulnerable. A cocoon is a silky web which is spun around the larvae of many insects. So this word has been used for immunization strategy also, which means that the people who are around that immunosuppressed individual should be protected and should be immunized. And so the vaccinations should be given properly to the household contacts in many diseases, they should be all fully immunized, and especially with regard to certain vaccines like varicella and influenza, which can create havoc with a immunosuppressed individual. As I said earlier, that the inactivated vaccines may produce a lesser efficacy and immunogenicity. So a higher dose, more number of dose, more boosters could be indicated in some, and antibodies titers may need to be checked after vaccination and on a special regular basis so that we have the person immunized. The third question is, how do you judge the degree or the severity of immunosuppression? Now, for this purpose, the CD4 T cell count is a very good method to use. Now, this CD is a cluster of differentiation, and CD4, this is a membrane glycoprotein which is present on the immune cell surface of the cells like the T helper cells, the monocytes, the macrophages, the dendritic cells, and so on. And these cells, they coordinate the immune response by stimulating the other immune cells, like the macrophages, the beta cells, the CD8 cells, and they help to therefore fight infection. Now, this CD4 cell count uh, can be lowered in many situations. Of course, the most important of these is the HIV infection. But there are many other situations like infections, for example, flu, for example, pneumonia, hepatitis B infections, cytomegalovirus infection, and then other things like autoimmune diseases, immunosuppressive therapy, lymphomas, and some idiopathic situations where the CD4 cell count is less. So one of the important things to do would be to check the CD4 T cell count, which is done by immunophenotyping by flow cytometry. And we can categorize the individual as to the level of immunosuppression and therefore decide whether vaccinations can be given and which ones can be given. So if the CD4 plus T lymphocytes are more than 25%, then there is no immunosuppression and all vaccines can be given. However, if this count is 15 to 24%, then we say this is a moderate immunosuppression. And so we have to see the risk benefit ratio and decide whether vaccination can be given to this individual or not. If the CD4 T lymphocyte is less than 15%, this is a case of severe immunosuppression. And as we indicated, that live vaccines cannot be given in these because the disease risk due to vaccine itself is high, but killed vaccines can be given, although with a lower efficacy. In children who are more than 5 years of age, a CD4 count of less than 200 cells per microliter, this suggests severe immunosuppression. The normal level would be 500 to 1400 per cubic millimeter. So if you have a child who's got less than 200, take that as a serious immunosuppression. Now let's come to some specific situations and what we should do regarding vaccination. One of the very common scenarios is steroid therapy. What should we do when a child is on steroids? Now here we can see that if the steroid administration has been for more than 2 weeks in a high dose, that means a dose of more than 2 milligram per kg per day, that is still about 10 kilogram weight, this dose, or more than 20 milligram per day in a child who's more than 10 years, then it can be categorized in that situation where live vaccinations cannot be given. This is a contraindication for live vaccines. So if a child is on this level of steroid for this duration, then you must give the live vaccines only 1 month after stopping the steroids. At the same time, as we said, the killed vaccines can be given, but the maturity being lower, we should keep that in mind. Now, if the steroids are given for a shorter duration, let us say less than 2 weeks, then even if the dose has been high and then it has been stopped, or if a dose is less than 2 milligram per kg per day, or this is an alternate day schedule with short acting preparations, or the child is on low maintenance dose like a replacement therapy, then in these situations, all vaccines, including live, can be given. Now, this is a very common question which pediatricians would have in mind, that the child is on steroids, should we give vaccination or not? So keep in mind that the dose and the duration of the steroid administration is important to make that decision. The other thing is that if the child is on topical steroids or inhaled steroids or local injection of steroids, again, there is no contraindication. All vaccines can be given in this situation. This is again a common scenario where, say, for bronchial asthma, inhaled steroids are be given. In this situation, any vaccine can be given. Now, which vaccine should be given with priority in a child with special situations like asplenia or hyposplenia or a child with splenectomy? Not a common scenario, but we know that in this situation, the vaccines against capsulated organisms are very important. Pneumococcal vaccine, meningococcal vaccine, and HIB, these are very important for these cases, and typhoid also should be given with priority. Now, another common scenario is a special situation where a child is receiving some blood products or immunoglobulin or antibody containing products. What should we do regarding vaccination? Now, there can be three kind of situations here. One is that the patient is receiving immunoglobulins and you want to, or you are planning to immunize. What should you do? The second scenario is if you are planning to give immunoglobulins and you are thinking about whether you can give vaccination before that immunoglobulin and how much time before. And the third is that if the patient has already received some vaccinations and now after the vaccination the child needs immunoglobulins, what should you do? So let's come to these three situations. The first one, that if the child is receiving or has received immunoglobulins, then inactivated vaccines, anyway, there is no problem. They are safe enough. The mucosal route vaccines like rotavirus or oral polio, they can be given at any time. And in fact, these immunoglobulins do not interfere with the immune response to even some other vaccines like yellow fever vaccine, no problem. Similarly, the live attenuated influenza vaccine also, they also do not have any interference with the antibody production. So these can be given. But vaccines which are live, like MR vaccine, these injectable ones, MR vaccine, MMR, varicella, MMR-RV, and the hepatitis A live vaccine, these have to be avoided for a period of time which ranges from 3 months to 11 months, which I'll come to in the next slide. And if you are planning to give immunoglobulins and you want to give these vaccines before the immunoglobulin administration, then there has to be at least a 2-week interval. That means that you first give the vaccination, wait for 2 weeks if you can, or if the indication is that you can wait, then that is acceptable, but not within 2 weeks of giving the vaccination. And if in case you have already given the vaccines, these vaccines, the live vaccines, which we are avoiding, then suppose you have a situation where you must give immunoglobulins after that, then obviously then if there is an indication for giving immunoglobulins, you cannot avoid it. But the vaccination status will have to be considered, that if less than 2 weeks have gone after the vaccination has been given and you are giving the immunoglobulin, then you will have to repeat the vaccination and take it as not given after the period, that is 3 months to 11 months, where you would normally have given it. But if the immunoglobulin is given after 2 weeks, then there is no need to repeat that vaccination. And this is because the virus replication and stimulation of the immunity takes place after 2 to 3 weeks of the administration of the vaccination. So the time interval between the vaccine and the immunoglobulin becomes an important issue. So this is a table which shows the gap which you need to maintain to give live vaccinations if you are using the immunoglobulins. So this can range from, as you can see, 3 months to 11 months in the different immunoglobulins. The tetanus or the hepatitis B, 3 months. human rabies 4 months, varicella, zoster 5 months, hepatitis A prophylactic dose 3 months, measles prophylactic dose 5 months, IVIG, which is in used in a relatively low dose like ITP 8 months, and high dose like in Kawasaki 10 to 11 months. The whole blood or PCV packed cells 6 months, fresh frozen plasma or platelet product 7 months, adenine saline wash RBCs 3 months. But there is no need to have any gap if they are washed RBCs, or if you're giving monoclonal antibodies for rabies, for example. We were having so much of discussion on monoclonal antibodies that if you have given monoclonal antibodies, there is no gap required for giving live vaccinations following that. Now, one of the common situations where you would need to make a decision regarding vaccinations would be HIV, because HIV is typically related to very severe infections, because there is a multifold enhanced risk of many infections like tuberculosis, hepatitis A, hepatitis B, measles, influenza, varicella, pneumonia, so many other infections. And so we have to decide about vaccination in these children. Again, here, the CD4 count is a very important parameter, as we have already discussed. The live vaccines are obviously contraindicated in severe disease because there is an uncontrolled replication of the virus. And so there is no way you can do it in a case of HIV where there is a severe disease. Inactivated vaccines can be given. If there is a low CD4 count and there is a loss of prior immunity, that means even if the child had been receiving full vaccinations before the diagnosis of HIV, that immunity is also gone. And so, therefore, in such cases, you may have to do antibody levels and you may need boosters routinely, even though they have been fully immunized earlier. In smaller children, the immune system is relatively well preserved. So, therefore, in a asymptomatic baby below 1 year of age, you can give all vaccinations. And this table shows the IAP and WHO recommendations with regard to the vaccinations in HIV in cases who are asymptomatic or symptomatic. In asymptomatic cases, all vaccines can be given because the immunity is preserved at that time. But in symptomatic cases, only the inactivated vaccine like DPT, IPV, Hib, and pneumococcus, they can be used. Cannot use BCG or OPV. But in case of measles, MMR, and varicella, if you have the CD4 count of more than 15%, then it is permissible to protect the child with these vaccines. Now, coming to another special situation, that is cancer, different cancers, and the children who are on chemotherapy. Here, in many cases, we would be planning the chemotherapy or radiation, and there may be a small time interval which can be available to us. So, preferably, all vaccines should be completed before the initiation of chemotherapy or radiation, if this is feasible. But if the chemotherapy and radiotherapy have been instituted, then at least for 3 to 6 months after that, all live vaccines must be avoided. And in case of varicella, this can be given only 1 year after stopping chemotherapy, or if the child is in remission, that means the platelet count should be more than 1 lakh and the lymphocyte count should be more than 700. The inactivated vaccines can be given during chemotherapy, but as we have been talking all along, the immunogenicity would be decreased. And so you would need to do antibody titers after the completion of chemotherapy, and booster doses of all the requisite vaccines would be needed in these cases after the chemotherapy and the treatment has been completed. Now, what about bone marrow transplant? Now, this is slightly different to the cases with the other, other cancers. There is already probably a underlying condition which is immunocompromised, and so the vaccine will not work. So at the same time, since this is a planned event, we should try to complete all the vaccinations at least 1 month prior to transplant. Now, we should also remember that vaccine immunity will be lost after the immunosuppressive therapy post-transplant, that means after ablation. And so, age-appropriate revaccination series will have to be completed in some such children, just considering them as unvaccinated naive children. So, what we are saying is that the previous vaccine immunity may be lost, and since either you should protect these children before you have started the bone marrow transplant, but even if you have, they will need a revaccination after you have completed the treatment. Passive immunization, SOS, post-exposure to disease, that has to be given. And the inactivated influenza vaccine, this is an important vaccine here, should be given every year starting 6 months after transplant, whereas the other inactivated vaccine should be started 1 year after the transplant, while the live vaccines like MMR or varicella should be deferred to more than 2 years after the transplant. The solid organ transplant, like say liver transplant, here the vaccination prior to transplant is of prime importance. And so a pre-transplant recipient should receive all the immunizations prior to the transplant, because in most cases you can plan out the timing of the transplantation, uh, at least in many cases. And so even if there is a short time available, accelerated schedules should be used so that you can complete as far as possible all the vaccinations. The vaccination with live vaccine, they should be completed at least 4 weeks prior to the transplant, both in the recipient as well as the donor. MMR and varicella vaccines, they can be given even to younger children. Normally, we would give MMR the first dose at 9 months and varicella at 15 months. But in such cases, if you're planning a transplant, they can be given even to 6 to 11-month-old infants at least 4 weeks before the transplantation. Now, what should we do after the transplantation for the recipient? The vaccination with inactivated vaccines can start 6 months after the transplantation when the immunosuppression has been lowered. And the influenza vaccine inactivated can be given as early as 1 to 2 months post-transplantation, especially if there is an outbreak of influenza. Boosters for inactivated vaccines should be given as per the schedule and when the antibody levels are waning, especially in hepatitis A and B in liver transplantation. And this should start 6 months after the transplantation. That means basically what we are doing is that we have to immunize these children as best possible before the transplantation, and after the transplantation we must monitor them and make sure that their immunity level is maintained. If not, then they would need booster doses, and we should ensure that the protection is complete. No live vaccines post-transplant. They can only be given 2 to 3 months after stopping the anti-rejection treatment. And so it's not just after the transplant, but when you have stopped the anti-rejection treatment, only after that we can think about the live transplant, live vaccines. Due to immunosuppressive therapy, post-transplant vaccination with live vaccines is not possible. So this is an important message which we should keep in mind for the solid organ transplants. Now, what about bleeding disorders and children who are on anticoagulant therapy, for example, in hemophilia? Here, we should prefer subcutaneous route wherever possible. I mean, there are some vaccines which we can give subcutaneous, like Hib, although normally they may be given intramuscular, IPV, PPSV. So you should avoid intramuscular injection in these cases. We should use less gauge needles, definitely 23 gauge or smaller gauge, so that we don't induce unnecessary puncture there to have bleeding. And as far as possible, we should have this schedule immediately after or soon after the administration or the replacement of the clotting factors. And when you give this vaccination, you should maintain good pressure, firm and sustained pressure for 5 minutes without rubbing. so that the chances of bleeding are minimized. And we should also keep in mind that some vaccinations cannot be given subcutaneously. The aluminum adjuvanted vaccine, so DPT vaccine cannot be given subcutaneously, and you will have to decide regarding administration intramuscularly in these cases. Now, there are some situations where there are comorbidities, and you are deciding about vaccination, like chronic diseases, for example. Now, live vaccines can safely be given in most of these situations because the immunogenicity, the efficacy, and the duration of protection, although maybe a little lower than in the other population, but still they can be given, should be given, and so we should not let these children remain without proper vaccination schedule. Of course, higher antigen concentration and more number of doses, for example, in hepatitis B, could be required in these cases because their immune response may be a little lesser, but there is no contraindication for giving these vaccinations. Some of these conditions would have some vaccines required on priority. For example, in chronic liver disease, hepatitis A, hepatitis B, and influenza vaccines are a priority. In pulmonary disease and cardiac diseases, influenza vaccine and pneumococcal vaccines are a priority. In progressive neurological disease, acellular pertussis has to be used, and we must avoid the whole cell vaccine. In chronic renal disease like nephrotic syndrome, the vaccines against capsulated organisms like pneumococcus, meningococcus, Hib should be used definitely, because these are common infections in nephrotics. And in cases where dialysis is taking place, then hepatitis B vaccination is very important. In cochlear implant patients, pneumococcal vaccine is very important because of the increased risk of meningitis and otitis. So in all these comorbidity conditions, we have to remember that vaccination is important, should be given, and some vaccines should be even higher priority. And at the same time, we must follow up the antibody response to these. And if necessary, we may have to give frequent, even boosters for these children. Now, some not so common but important conditions in which the immunodeficiency is there can be also considered like primary congenital immunodeficiencies like primary B or T cell lymphocyte defects or combined deficiency. Here again, the response is less and less efficacious with vaccines. Some vaccines are contraindicated, like live bacterial vaccine or live viral vaccines. Most of them, anyway, are receiving regular IV immunoglobulins. So those contraindications which are there for children receiving immunoglobulins have to be kept in mind in these situations. Inactivated or killed vaccines can be given, but they are not so effective. And only in cases with only B cell defects, live vaccines like measles and varicella can be given. Complement deficiency, all vaccines can be given and they are safe. And in C1, C2, C3, C4, pneumococcal, meningococcal, and HIV vaccines are important. In C5 to 10, complement deficiency, meningococcal vaccine is important. And influenza vaccination is also important to prevent secondary infection. In phagocytic disorders like chronic granulomatous disease, again, all bacterial vaccines are totally contraindicated, but live viral vaccines can be given depending on the situation, especially for chronic granulomatous disease, they can be given. In the others, sometimes they are not. Inactivated vaccines can be given. Influenza vaccine is important, and pneumococcal vaccine is also very important. And this is the last slide here. What about pregnancy and lactation? All live vaccines are contraindicated in pregnancy because of the theoretical risk to fetus. So they should not be given during pregnancy. But inactivated vaccines are safe, but only if you think that the risk of disease is high and they are indicated. Otherwise, it's better to wait till the postpartum period, because all these vaccines can be safely given in the postpartum period. Only yellow fever virus is the one which we should avoid giving in lactating mothers. Otherwise, in the postpartum period, all vaccines can be given. During pregnancy, we know that tetanus vaccination is important. So TD, Tdap, influenza vaccine, COVID vaccines, all these can be given. Rabies vaccine should be given if indicated. Obviously, there is no choice here. Hepatitis B vaccine can be given in pregnancy. So we have to keep in mind that this is not really an immunosuppressed condition, but it is just a condition in which there is alteration in the immune status. So I think these are the slides which I had. I'll stop sharing here and we can come for any discussion later or now.
Dr. Gambhir and Dr. Bode.
Yeah.
Dr. Harpreet.
Dr. Bode, will you take over?
Thank you, sir. Am I audible?
Yes, yes.
Yes, you are audible.
Thank you, sir. Thank you, Dr. Gijit, sir, for enlightening us on this very sensitive topic of vaccination in special situations, especially in babies we find with cancer, ALL, or born to HIV positive mothers. It's been a very good discussion. We'll move on to the next presentation now by the concerned. Hello. We'll be moving on to the next and the concluding presentation by Dr. Sagar S. Kulkarni, who is MBBS, DCH, DNB, and who is the brain behind all this scientific. He's a national scientific convener of National Vaccinology Module, DIP 2021 to 23. And we'll be thankful to him, who has made this possible to be held through LAP. And presently, he is the owner and director of Bhakti Children Hospital, Lakshmi Nagar, Aurangabad, Maharashtra. He is also a faculty in International IPA Congress, Pedicon National Conferences, West Zone Pedicons. He is a faculty in state conferences like Mahapedicon, Mahaneocon, and faculty in regional pediatric conferences. He is National Faculty Vaccinology PVC Workshop, Central IAP, Basics and Beyond Workshop. He is also course coordinator, Vaccinology Module, IAP Aurangabad for the last 8 years. Sir is a faculty in Government Vaccination Training Program for Medical Officer. He is editor-in-chief and contributing author, Vaccinology Simplified Book, and contributor author book for adult immunization in office practice. I'll request Sir to kindly take over for his next presentation for adverse event following immunization and anaphylaxis. Kindly over to you, sir.
Thank you so much for those kind words. And still a student of vaccinology, because we read so much, but at the end we think that no, we are not read anything, and there is so much to learn and learn. The learning never stops. So coming to the last topic of this session is AEFI, and if we see the standard definition, any untoward medical occurrence which follows immunization, but which does not necessarily have a causal relationship with the usage of the vaccine. What does this mean? That it can be an abnormal sign, symptom, disease, or even a laboratory finding. Now, we have to understand that whenever an AEFI occurs, we have to put it in some of the other categories. So it can be a vaccine product related reaction. It can be vaccine quality defect related reaction, immunization error related reaction, immunization anxiety related reaction, and the last one will be coincidental. So what does this mean by vaccine product related? That means that it is because of the inherent properties of the vaccine product, and we cannot do anything about it. Number two, vaccine quality. That means there was a defect in the production of the vaccine or in the production of the administrative device which was provided by the manufacturer. Immunization error is definitely related to healthcare workers. So we have chosen a wrong vaccine. We have given it to a wrong patient. We have used in an improper route. We have not followed the standard guidelines. And because of that, immunization error occurs. Let me tell you, friends, amongst all these types of AFI, which is the most common AFI type is immunization error related only. So that is in our hands to actually reduce this type of AFI. The next is the immunization anxiety related. So though not exactly related to the immunization, but related to the immunization process. So that person might have an immunization anxiety related reaction even before giving injection. The last one is a coincidental. For example, let us say a child was given DPT and after 3 days the child landed up with malaria. So it has nothing to do with the vaccine. So it is a coincidence. Few examples of vaccine product related reactions are like, let us say, swelling after DPT vaccine, or if the child landed in hypotensive, hyporesponsive episode, or there was arthralgia, there was arthritis. So these are all vaccine product related reactions. What is a quality defect? So we know all these famous cutter incidents which occurred in past, that IPV was given, it was not inactivated properly, and many children, they had paralytic polio. So some such vaccine quality defect is called as a AFI of that type. Other can be the administrative device can itself be faulty. So faulty syringes, faulty needles come into this. Immunization error we have already seen. So suppose we have used a used syringe and there was a transfer of hepatitis B or HIV, that is a grave mistake. It comes under immunization error. We have given a expired vaccine. We have given a vaccine which was damaged by cold chain. We have given a wrong vaccine to a wrong patient. This all comes under immunization error. In immunization anxiety, the most common is vasovagal syncope, and it can occur not only during injection, but sometimes even before giving the injection. Other types of immunization anxiety are like hyperventilation, vomiting, screening, and sometimes we have even seen a convulsions also as a part of immunization anxiety. Coincidentally, we have just seen. So some tricky examples, let us see that a doctor was giving an injection, the child was moving his limbs violently and the needle broke. Now we have to categorize this as which type of EFI it is. So what is the example of this? Now this one was immunization error related because we have not followed the standard procedure of restraining the child. Now let us see the same example with a different perspective. While giving injection to a child who was adequately and firmly restrained, the needle broke. Now which type of EFI it is? Now this will become a vaccine quality related because the needle or the syringe was not properly manufactured by the manufacturer. Another case, maculopapular rash with fever was there on day 2 after giving a measles rubella vaccine or a MMR vaccine. Now, is it a vaccine product related EFI? We have to understand the time frame in which the EFI is offered. Now, we know that MR vaccines and MMR vaccines can cause fever with maculopapular rash, but it causes that in the second week, that after 7 days. So this baby had a maculopapular rash with fever on the day 2. So it does not match in the time frame. So it is not a vaccine product related EFI. And you will have to find out some other reasons. Might be that the child was in incubation period. The child might have been exposed to the disease earlier before even the vaccine started acting, or there might be a different diagnosis of any viral fever with exanthem. Okay. So time frame in which the EFI occurs is very, very important. Next question is what to report as EFI. We have to report it to the local government official. Any serious, severe, any EFI which required hospitalization or even admissions, they have to be reported. In case of a newly introduced vaccine, like say we have given COVID vaccines recently, in those cases, any signals and any events, even of mild to moderate variety, we have to report. EFI that may have been caused by immunization error definitely have to be reported. All events specifically in the day 30th have to be reported, but this 30-day definition is not standard. Any AFI occurring at any interval which is causing a parental and community concern has to be reported as an EFI. What should not be reported as an EFI? Simple like fever, headache, local pain, swelling, irritability, malaise, all these things we don't report. Even vasovagal attack, we don't report as EFI to the government authorities. As an office practitioner, what is our job is to report to our local area regional government medical officer, and then he will pass on the information to the district immunization officer, who will pass on to the state immunization officer, and so on and so on. And though this chart mentions what exactly should be done, basically it is for public health perspective and is not related to the office practice. From case notification to filling up different forms to causality assessment and what should be the interval within which these all things have to be done is mentioned in this chart. There is another way of doing it, that there is this ID Serve website from IAP. We can report it on that, and in turn they will report it to the government. That can also be done. I have already said there are some important things. The time frame of AFI event has to be taken into consideration, whether it really fits in that time frame. Another example which I would quote, like a febrile conversion occurring after DPT. Now, fever will occur after DPT in, let us say, 2 to 3 days. But if fever occurred after 15 days, does it fit into that? No, it does not fit into that. So time frame is important. You have to take a proper history, medical history, treatment history, similar episode history. Now, the child might be a case of seizure disorder and might be landing in seizures repeatedly. But when you give vaccine, the child lands into seizure again. Don't blame the vaccine for that. So for that, the proper history taking is very, very important. Remember, friends, EFI reporting and surveillance is not to blame anyone, but it is very important so that we can take further actions based on the data which is generated. Media management, of course, very important, because if it goes out to media in a wrong way, that can lead to vaccine hesitancy. I can remember one such episode of staphylococcal toxic shock syndrome, which occurred in my area few years back, and literally a whole public from government to private sector, they stopped taking measles vaccine for literally 3 to 4 months, and lots many convincing had to be done to remove the vaccine resistance. If a AFI occurs in your private practice, preserve the vials and use syringes if it occurs immediately. Preserve definitely the temperature charts. We have seen in the cold chain lecture which we have taken. You have to have temperature charts in your vaccine. You have to maintain the proper cold chain. All these records, the purchase records of vaccine, everything you have to prepare. IAP members and pediatricians are always a part of the government AFI committee in each and every district. So we have to be very well versed with this AFI, its types, and what exactly we have to do. Coming to a part of that AFI is the anaphylaxis, which we are going to discuss only about the vaccine related. Now, the first question, what is anaphylaxis? Which type of AFI it is? It comes under the vaccine product AFI, because no one can be blamed for that. It is basically dependent on what is present in the vaccine. Anaphylaxis can be because of vaccine antigens, stabilizers, antimicrobials, preservatives, excipients, and allergy to the mediums in which vaccine was prepared. So anything which is there in vaccine can actually give rise to anaphylaxis. The tricky part here is sometimes maybe a combination vaccine. So we have given a pentavalent vaccine or hexavalent vaccine, and the AFI like anaphylaxis occurs. And now the next doctor is very much worried whether should we give a pentavalent and hexavalent again, and the child might be deprived of so many important antigens. That is a tricky part which we have to solve many a time. Remember, there are two types of anaphylaxis. One is the immediate, which occurs in hardly 15 to 20 minutes, and the second was a late phase, which occurs in around 24 hours. It is rare, but it occurs in 6% of the kids, and this late phase is because of eosinophilic recruitment. So even if a child comes to you with anaphylaxis after, let us say, 10 hours or 15 hours, is it anaphylaxis because of vaccine? Yes, it can be because of the vaccine. A few examples. But there was this 15 years old female who was being given HPV. She suddenly fell down, became unresponsive. Now relatives started shouting, reaction. But really, do you think this is anaphylaxis? Now you have to understand the difference. Vasovagal attack occurs immediately, even sometimes even before pricking the patient. But for anaphylaxis to occur, at least a gap of 15 to 20 minutes always is there. And then you have some respiratory problems, some wheezing, some urticaria, even tachycardia. But in vasovagal attacks, these are not going to be there. So we have to have the capability to differentiate between anaphylaxis and a anaphylaxis mimic. Now, what does WHO say? Yes, sometimes there can be dilemma, sometimes there can be confusion. How to solve it? If there are more than one signs or symptoms in any two of the systems, which systems? Respiratory, cardiovascular, or dermatological. Now, why we have chosen these systems only? Because these are the systems which are rich in mast cells, and therefore the signs and symptoms appear in this system on a priority basis. So these three systems are preferable. Now, it can be seen in gastrointestinal system, also like in the form of vomitings or loose motions or cramp, but basically these three systems are very important. Respiratory system, you can have a stridor, wheezing, cyanosis, grunting, swelling of the tongue, and so on. Cardiovascular, there is always a fall in the blood pressure, and because of that, there is loss of consciousness, tachycardia. And dermatological, you can have urticarias, erythema, rash, swollen face, or swollen tongues, and so on. So we have to judge by that. Now, one such example, I remember there was a child, and when a prick was given, the child suddenly stopped breathing and the lips turned bluish. Now the question, it is anaphylaxis. So you have to understand that this is anaphylaxis mimic because it is a case of simple breath holding spell and not a case of anaphylaxis. Now the question arises, should I give adrenaline or should I not give adrenaline? Sometimes confusion appears. So withholding adrenaline versus giving adrenaline, always give adrenaline when there is doubt, because there are not much side effects of adrenaline, even if you have given it inadvertently. Remember, friends, an emergency tray should be ready in your clinic. Anaphylaxis is not a doctor's mistake, but not equipped to manage anaphylaxis and not managing anaphylaxis adequately definitely comes under medical negligence. So you have to have adrenaline, angiocat, IV fluids, all oxygen, etc., in your AFI kit. As far as steroids are concerned, no. Steroids, Avil, Dexona, these are not a part of first-line treatment because the time of action is very, very slow. The only main treatment is adrenaline. Don't dilute it. Use only 1000. You have to use it intramuscularly only, strictly, not to be given subcutaneously. And don't waste time in achieving IV access because we don't need it IV also. IM is the only route. If you know the weight of the child, well and good. Use 0.01 ml per kg per dose. If you don't know the dose, there are charts which are available in the EFI and the anaphylaxis kit based on the age of the child, and you can use that chart and give the adrenaline. Give only IM on anterolateral thigh. If the sign symptoms persist, you can repeat it after the 5 minutes. Other ABCs, airway, breathing, circulation, we all know, depending on the pulse model, you can do it. Where does antihistaminics and steroids stand? It is not a first line of treatment. But if at all you want to use it, you can use it to prevent the late phase reactions. Oral antihistaminics and oral prednisolone can be used to prevent the late phase reaction, especially if the child had needed admissions and IV fluids and other resuscitative measures. We give this and then discharge the child for 2 days. That is the only role. Otherwise, the main treatment is adrenaline only intramuscular. So this is a chart which is present in the EFI kits and anaphylaxis kit. It is even available with the healthcare workers of government setup also. You can use that chart. So that's all. Thank you very much. And I hope you all enjoyed this module. Thank you. Any questions, if they're remaining, we'll take it before concluding. Thank you.
Thank you, sir. Thank you, Dr. Sagar Kulkarni, for wonderful talk on AFI and anaphylaxis. And one good takeaway from this thing is, while in OPD practice, always keep the emergency tray ready by your side, because this is most private practitioners, they don't have, especially and the maintenance of other airway, you need to have some ambu bag kit as well alongside, because this may happen all of a sudden and the things may come out of turn and the baby may go unresponsive at any time. So there's one question for Dr. Ranjit sir. What should be the time interval between PCV, MCV, hip vaccine for immunocompromised patients? This has been asked by Dr. Meenakshi Singla.
Sorry, say that again. Interval between?
So between PCV, MCV, hip vaccine for immunocompromised patients.
Okay. Well, I mean, there's no separate recommendation for this. It would be, as we have already said, that if indicated, and especially if an accelerated rate is required, and you're planning, say, immunoglobulin later or a transplant later and such situations, then they can all be given together. All different vaccines can be given on the same date. But the minimum gap between, as we know, between two which are not live, I mean, inactivated vaccines is okay. I mean, normally we would do it at 15 days, but there is no recommendation regarding a minimum gap between two inactivated vaccines. I would give them all together if they are really required.
I would like to add one thing. Might be she must be confusing with the question she wanted to ask, that in a case of osteopenia or hyposplenia, can we give a PCV and MCV vaccine together, or is there a gap needed? I think that's what she wanted to ask.
Maybe. The takeaway message in that scenario of special situation vaccination would be like, if you want to go for a baby with chemotherapy or a bone marrow transplant, at least make sure that you get all the things vaccinated before 4 weeks of commencing the treatment, or in case you want to give live vaccine, wait for at least 10 to 12 months post chemotherapy or post bone marrow transplant. Am I right?
Actually, there are, for different kind of situations, there are different guidelines and different recommendations. And I feel that our purple book is very good. I mean, it is a reference book we should always be having on the bedside and in our clinics. And for a specific situation, the best is to look into the standard recommendation for that particular condition, because there are some differences in the different immunocompromised situations. So the best is to follow the guidelines which are given for that particular condition.
Sure. Sir, any proper history of the siblings we should take before vaccinating a baby? whether a elderly may be having some ALL kind of a thing or a nephrotic syndrome at home. We usually don't ask the parents, how many children do you have priorly they have got vaccinated any kind of a disease. We are just focused on the patient who's presenting to us most of the time.
It's an interesting point. But hopefully, the parents would volunteer that kind of information if a sibling has a serious disease. But you're right. I mean, normally nobody asks about some of these conditions, whether they're present in siblings.
Yeah.
It's a good thought that while we are taking a history, we should also think and talk about the other siblings and whether they're healthy or whether they have any disease.
Now, mostly if they have a normal baby, the second time or the third time around, they are hardly in that frame of mind to even share that they had some baby with some issues in the past also.
No, I don't know. I don't think that is true because you may have the sibling of the same patient coming later on, because if they brought the child to you for vaccination for a younger sibling, then the older sibling hopefully was under your treatment too.
I would add one thing that in rare situations, let us say there is a macrophage defect, interleukin axis defect. If the earlier child had a very severe reaction to live vaccine, that will become a contraindication to the next sibling. If there is some such specific history, definitely even BCG will be contraindicated in the newborn. You'll have to investigate it for macrophage defect because that is autosomal dominant or autosomal recessive defect, and then you'll have to think whether to give BCG also to anyone. So yes, in some such rare situation, family history or sibling history will be very important. The first child may be a child of hemophilia. So the second child, when you give intramuscular, you might find a big bruise or a contusion, and you might not have missed the history of hemophilia in the earlier child. So that can be presenting feature also in this younger child.
I think moral of the story is anyway, you should take a good history, not just the vaccination, but the general history of every child who come across, including the family history, which include the siblings.
So as per the slides, if you have a baby of positive HIV patients, those who are on ART, and they don't reveal their CD4 counts and the baby is brought by a grandparent to you, in that scenario, you are not going to do a CD4 count before 3 to 6 months in the baby. Should we start vaccinating the baby right then and there?
Yeah, as we were mentioning that in asymptomatic babies, the immune system is not that affected, and in the first year of life. So therefore, in the first year, asymptomatic baby, you can go ahead and give the vaccinations.
Thank you. Thanks a lot.
Add one point here. There is the WHO now recommendation that HIV testing is now available in every nook and corner of the city. So all these recommendations were at those time when HIV testing was not available. So we used to say, asymptomatic baby, please give the vaccine. Now what they say that you please check the child. If the child is HIV positive, you wait. You give ART to the child. Let the child again become immunocompetent and give BCG 6 months after the child has received ERT or after doing the CD4 count. That is the recent WHO recommendation.
In that scenario, at what age the CD4 count should be done?
1 year.
At 1 year, and you have to wait for 1 year for getting the child back.
Otherwise, the child might land up in BCGosis.
I think I can add to
that's just for BCG, I think.
BCG.
So what we practice in our hospital, I can just share that if mother is on ART, in that case, there is no issue with the live vaccine. So that can be given at birth, BCG and OPV both. But if mother is not on ART, in that case, although WHO guidelines is exactly what the Dr. Daljit Singh has said, but what we do, we avoid giving this OPV and BCG unless we are sure that this child is not having severe immunosuppression. But as Dr. Sagar has said, the risk of BCGosis is quite high if this child is going to develop HIV. So in that case, at 6 weeks, we do that, whether it is positive or negative. If that is positive or negative, and then we decide whether to give that or not. At the same simultaneously, we'll put the child on ART if that is positive, and then see CD4 count, and then decide. That way it goes. But if it is negative, then probably 6 weeks you can give that vaccine.
There are one or two other special situations which we didn't cover. I mean, they were not in the slides, but they are common. For example, egg allergy. I mean, egg allergy is fairly common. And I think everyone should be aware of what to do in this situation. Earlier, people used to be scared of giving MMR and measles vaccine to these individuals, but it is known that only yellow fever vaccination is avoided in egg allergy. Otherwise, in usual cases, even if you have a history of egg allergy, you can give all these vaccines, measles and MMR also. And if you have a history of hypersensitivity, like if there's a minor reaction to a vaccine, then you can still give the next whatever vaccine is due, but taking care that you observe the child properly for at least 15 minutes or a little longer so that you can take care of any adverse event.
Thank you, sir. Thank you. I'll next now hand over the forum to Dr. Tej Chabda, Secretary LAP, for his concluding words.
Sir, yesterday a point was discussed regarding keeping the immunocompromised contact away from the child for at least week or 2 weeks after giving oral polio vaccine and rotavirus vaccine.
Polio vaccines are not given to contacts also of immunosuppressed. As far as rotavirus vaccine is concerned, it is given to the contacts of the patient. When the child is given rotavirus for the first time, the replication is more. So the caretakers have to do handling or the hand wash for 2 weeks, because for the first time the replication goes on for approximately 2 weeks. So the answer to that is 2 weeks. But for the second dose, the replication occurs for approximately 1 week. So the answer to that is 1 week. So for 1 week, the caretaker has to do hand washing and proper care after handling the diapers. But to contacts of immunosuppressed, you can give rotavirus vaccine, but not OPV.
Sir, I think Dr. Sanjay is probably the busiest person today. So there is another question which has come to me on my WhatsApp. The question is, for how long post-exposure prophylaxis against rabies is protective in persons with close contact having repeated scratches from the pet?
Yeah, that we have discussed in the question.
So, like we said earlier, there is no upper limit of post-exposure prophylaxis.
Okay, right. Any other questions?
The point which I was
one question.
The last point I would like to say is that in osteopenia cases, PCV is given earlier and MCV is given later, and a gap of 4 weeks is kept, especially only in osteopenia cases, because there were some report that some serotypes of PCV will not respond better if both the vaccines are given together. The last comment from my side.
One question, can I ask?
Yeah, please.
Sir, in actually many times embassy people, they come and they ask for adolescent vaccination. So from the different speaker, what is the maximum number of injections somebody can apply in a hypothetical scenario for this unvaccinated people?
Any number on any given.
So there's a question about
on a single limb, 2 doses here, 2 doses there, on hand 1 dose, 1 dose. Even you can give 8, 10 injections on a single day. So there is no limit.
No limit, yes.
Sir, there is a question about live flu vaccine is being in US.
Is it available? I don't know.
No, it's not available, Ritesh, with us.
There is a query about live flu vaccine, which is available in US. That's what has been.
I don't know. I really don't know.
In India, it's not available currently.
In India, it's not available. The question is about US.
In US, it is available. I said 2
idea.
to 49 years, they are giving annual vaccination for all the healthy adults. They are using nasal flu vaccine.
Okay. That is live.
Yes.
The question is it available at present as we are speaking, the live one?
Oh, yeah, they want your opinion on live influenza vaccine.
I'm doubtful.
Live vaccine is equally effective in healthy individuals, but it is not available in India. That's why there is not much use of discussing that.
There are 2 new vaccines which have come up, the cell culture vaccine, Flucelvax and Flubevax. So they are cell culture vaccines and not egg culture vaccines. So they are now used there and said to be better immunologically in those countries.
And there is a lot of work going on currently on universal influenza vaccination. That means you don't need to change every time vaccination, every season you don't need, but you need to take it every yearly. So that is only in early stages, but that is something, a concept which is very being discussed these days. And second, the mRNA vaccine for influenza is also in the pipeline. So that will be the one probably in the coming years we will have mRNA vaccine that is very easy to produce compared to these older kind of vaccines.
So my question to Dr. Diljit sir is, current scenario is post-COVID, the mothers, those who have received Covishield vaccine, and within 6 to 8 months, they are getting pregnant and have delivered a baby. Many babies we find across, they have some cardiac issues or they have some features of MISC post in their neonatal period within first 7 days of life. Does it somewhere correlate to that vaccination schedule?
No, I have no idea. Maybe somebody can.
I think
vaccinations are proved to be safe in pregnancy. I have not heard of this. Do you have some such data available in your institute?
Yeah, there are many babies, those who have IgG levels on the higher side, and those mothers have received vaccine 1 year prior to that in 2021 or 22.
No,
Maybe
cardiac issues. I mean, cardiac issues.
Cardiac issues they did have. They may be having some cyanotic CHDs out of bounds, unexplainable to that, but they do have some LV dysfunctions.
I think this issue of this MIS-C in newborn is more overhyped. That is what I feel retrospectively now. And the developing cardiac defect in baby is something very new to me, because I'm not aware whether anything like this has happened. Although there are some reports of having thrombotic events in adults when it was given. But cardiac effect was more associated with the mRNA vaccines, which were used in the West. We didn't use much in India. So that is what, but we need to be careful.
Any other questions or queries?
I think there are no more questions, so we can.
Can we have, is Dr. Randhawa here?
Yes, yes.
Randhawa, please propose a vote of thanks for all the dignitaries who have made this program possible.
Thank you, Ritesh. Starting from CIAP, currently being led by Dr. Upendra Kenjwadkar, then immediate predecessor, Dr. Ramesh, incoming predecessor, Firebrand Baswaraj, then for this module particularly, Dr. Sagar Kulkarni. Thank you for being with us all these days. This is such a topic, day in, day out, even on the WhatsApp, we have 2 vaccinology groups and daily there are queries.
True.
This is something which is learning each day. And I will add another scenario to Dr. Bode's query, as we have kept in the slides also nephrotic syndrome as one of the condition, and pregnant female in the family. That can be another thing we can ask for when we are administering live vaccine. I thank good friend Dr. Sanjay, Dr. Diljit sir, ever ready to teach us all the time. Dr. Harpreet, Dr. Vinita Arora, my immediately predecessor, IAP State President, for conducting, Dr. Sunil Mehta, and all those who joined today, Dr. Gurdeep Dhuria, and Ritesh for very nicely planning and execution, both this particular module together. एक कल्ला 2-11 इकट्ठे होके हमेशा ही काम वधिया हो जाता. And I will request CIP to issue all online programs both to Ludhiana branch and state branch till 31st December at least.
Thank you, Dr. Darlaji, Malhotra ji, Dr. Singhal ji, Dr. Ritesh Chabra, IIP Punjab and IIP Ludhiana. Thank you so much. Thank you.
Thank you. Thank you. Dr. Shashi also.
Thank you all the speakers for the nice presentation.
Thank you very much. I think that
thank you to all speakers for giving their valuable time. Thank you.
Thank you.
Physically.
Goodbye.
Okay. Goodbye.
Thank you. Thank you, sir. Thank you.